On behalf of scientific and organizing committee, I have great honor and pleasure welcome all the attendees of 9 Scientific Conference of Innovations in Biomedical Engineering. The conference is organized by Faculty of Biomedical Engineering, Silesia University of Technology, and by American Heart of Poland, represented here by Professor Krzysztof Milewski. Welcome, Professor. The conference is a part of faculty's 10th anniversary celebration. Unfortunately, the conference, unfortunately, the coronavirus pandemic interrupt us to organize the conference in a traditional mode. That's why we meet you using tele-link. Let me to welcome the authorities of the Silesia University of Technology Rector, Professor Arkadiusz Mężyk. Welcome, Rector. We welcome Vice Rectors and Deans of our university. I welcome Mayor of the City of Zabrze, Małgorzata Mańka-Szulik. I would like to welcome the members of the Scientific Committee and members of the Program Council of the conference, the members of the Committee of Biocybernetics and Biomedical Engineering of the Polish Academy of Science. Let me to welcome the members of the Biomedical Engineering Discipline Council of the Silesia University of Technology and the deans of the Polish faculties where biomedical engineering studies take place. I welcome the representatives of the medical community. There are with us representatives of the industry related to biomedical engineering. I welcome CEOs, directors, and presidents. In particular, I would like to welcome the representatives of Philips Company, a strategic partner of the Faculty of Biomedical Engineering, headed by Vice President Willem Scheijgrond, Vice President, Global Head, Government and Public Affairs, Royal Philips. Welcome, the President. Especially warmly welcome the session keynote lecturer, Professor Bochenek and Professor Meyer. Welcome, professors. We are delighted to welcome all participants of the 9th Scientific Conference, Innovations in Biomedical Engineering. Now I would like to ask Professor Milewski to tell few words as a co-organizer of the conference. Professor, please take the floor.
Thank you very much. It's my honor to represent American Heart of Poland, the largest company that works in the field of hospitality and scientific medical innovations in Poland. We are the largest network of private hospitals in Poland that treat mainly cardiology and cardiac surgery patients. But we are not only physicians, we also work as a scientist. We have a large center for research and development. That's why we are the co-organizers of this excellent conference. And this is the 3rd time that we are organizing this excellent event together with Silesia University of Technology. We are together with our physicians and younger colleagues, including students, medical students. We know how important it is to cooperate with young engineers because I believe that only strong relationship between physicians and medical engineers can bring us to the better future, bring better healthcare to our patients. So that's the reason that we are together. I hope this session will be very interesting for all of us, and we will have a great opportunity to listen to very important and interesting lectures. Thank you very much.
Thank you, Professor, for your kind words. And now I would like to ask Rector, Professor Arkadiusz Mężyk, to welcome our attendees of our conference. And please, Rector, start the first session of the conference. Take the floor, please.
Thank you very much, ladies and gentlemen. I'm very pleased to welcome all participants of the conference Innovation in Biomedical Engineering, co-organized by the Faculty of Biomedical Engineering of the Zaproszenie University of Technology and American Heart of Poland, which is our partner for many years. Unfortunately, due to the possible contact with the people who may be infected, I do not personally participate in the opening of today's conference. This year's edition of the conference takes place in an important year of the 75th anniversary of the Zaproszenie University of Technology and the 10th anniversary of the establishment of the Faculty of Biomedical Engineering. For many years, this conference has been a meeting place for scientists in the field of biomedical engineering and has become a platform for the exchange of experiences between representatives of science, industry, business, and medicine. This year conference takes place in a new situation. It has a new meaning in the context of the pandemic and the role of the biomedical engineering in minimizing the effects of the epidemic. I also greet Royal Philips, our partner in Assist Sport Med Silesia, the largest project in the region with foreign capital. Thank you very much for your cooperation so far. However, I wish the participants of the conference fruitful discussions and inspiring discussion. And at the very beginning, we will start with the presentation of Willem Scheijgrond, Royal Philips, Vice President, Global Head of Government and Public Affairs. Willem Scheijgrond heads up a global network that is responsible for the relation with governments and related stakeholders to address societal challenges, in particular in the area of large-scale healthcare transformation. Willem is also responsible for the Philips relations with international organizations such as the United Nations, international development institutions, and internal NGOs. Ladies and gentlemen, biomedical innovations for the next decade. Willem Scheijgrond, Royal Philips. Willem, please take a floor.
Thank you very much. Thank you very much for allowing me to present at your conference and at the 10th anniversary, and congratulations once again. I believe that you will see my screen now. Is that correct?
Correct.
Yeah. So thank you. I will present about the biomedical innovations for the next decade, or at least my perspective from Philips. This comes at a time that the students that are in the audience are, of course, starting a new academic year and wondering in what time have they arrived. Well, apart from the celebrations of the university that are virtual, we are also in a crisis. But as you all know, it's also good to celebrate and use the opportunity that a crisis provides. So I wish you a very inspirational next new year, realizing that this may be the most bizarre year that you're going to experience, and I hope you use that to the maximum to become innovative. Philips is a global leader in healthcare technology, active in more than 100 countries, and we have developed a strong purpose where we said we will make the world healthier and more sustainable through innovation. And can you hear me? Yeah. Will aim to improve the lives of 2.5 billion people per year by 2030. Now, for those of you that are following the United Nations and the discussions there, you will see that this is very nicely aligned with the goals of the Sustainable Development Goals, the 17 goals that set the societal agenda for the next 10 years. As the UN says, we have entered in 2020 the decade of delivery, or the decade of implementation. As Philips, we have said, our biggest contribution towards society is to improve access to quality healthcare, so SDG 3. But of course, we also need to respect the impact that we have on the environment. So we'll do whatever we can to reduce our impact on the climate, and promote sustainable consumption patterns through, for example, circular economy. Now, in this presentation, I want to talk about our view on healthcare. What have we learned of the transformation of healthcare during COVID? And what do we expect that transformation to look like once we have dealt with COVID, and perhaps already starting during COVID? And ultimately, perhaps leave you with a challenge of how you could innovate with us in partnership to address the challenges and ensure that in 2030, everyone around the world has access to quality care. This is the continuum of care, and we like to use the continuum of care within Philips to explain how people and healthcare professionals travel through the healthcare system throughout their life. And as you'll see on the left, everybody hopefully starts out with a healthy living. We live a healthy life, and as Philips, we try to support it with solutions. And as you move through its life, we'll also help you prevent getting sick, and preventative measures such as population screening and other tools to see that those people that may be in a higher risk category, that we do whatever we can to prevent them from, for example, becoming obese and therefore developing hypertension or developing cardiovascular conditions. But we also recognize that people will fall sick multiple times during their lives, and that the diagnosis then has to be precise and very fast. You want to get it first time right. You don't want patients to have to come back time and time again to do the same diagnosis. Unfortunately, that is the situation today. And especially in areas where diagnosis is so crucial to get it right the first time, for example, when you've broken a leg, you want to make sure that the diagnosis is done properly, but also in more complex situations like in oncology, you want to make sure that that diagnosis is done quickly. Now, for cancer patients around the world, it is not uncommon that the diagnosis takes more than 6 months to have a definitive diagnosis of the oncology of the cancer. And that, of course, stands in the way from treatment, but it also has a phenomenal impact on the patient's mental condition and the stress levels in the family. So diagnosis, get it right first time and do it fast. And then we can move to treatment, like interventions in cardiovascular conditions, but also oncology planning, all those kind of things, and make sure treatment, as far as possible, is non-invasive. The times that we're going to cut open patients should be behind us. We should move towards non-invasive therapies, because that also allows us to treat patients outside of the hospitals in environments that maybe you wouldn't have thought of before. And finally, after treatment, let's make sure the patient goes home as quickly as possible, because ultimately that is the place where the patient recovers fastest. And you'll see that people go through this several times. And leading in the innovations that we're trying to plant along this continuum is the quadruple aim. In your innovations, we need to make sure that we improve the patient experience. Now, the patient experience is different than the patient outcome, which I'll come to next. But the patient experience is critically important. Patients are more empowered. They feel that they have more control over the healthcare system. They demand better access to care. They want to be treated with dignity, and they definitely do not want to be sent from one doctor to the other and having to repeat the same things over and over again. Registering your name again, telling the story again, redoing all the diagnosis, running around, traveling far distances. So how can we improve the patient experience is critically important, because if a patient feels more at ease, the health outcome will probably also be better. So that's the second thing. We also need to improve the patient outcomes. So not only the survival rate, but also the quality of life and the side effects of interventions. And can we guide them through that decision-making process, in particular in cardiology, but also in oncology? the different treatment options give different outcomes, and we need to match those with the expectations of the patients. And that requires better patient interaction and better understanding of what a good outcome for a patient looks like. Thirdly, improve staff satisfaction. Especially during COVID, we've seen that stress levels among staff has been very, very high. Burnout rates are amongst the highest in any profession in the healthcare sector. So how do we improve staff satisfaction? How do we make it easier for them to spend less time on, for example, getting the right parameters for a CT scanner before they start their procedures, or not walking around all the time, having to go and looking for equipment. We know that nurses walk about 10 kilometers a day just looking for stuff. How can we improve staff satisfaction? Interesting to see that after the COVID crisis, a lot of staff in the hospitals want to leave the healthcare sector. It's not the money, it's just dissatisfaction. And finally, how do we improve productivity and lower the cost of care delivery? We will all need more care in the future, and we all want it better. We have multiple chronic conditions that need to be managed at the same time. We can only continue to improve better care if we find a way to decouple that from the increase of cost. So, and there digitization comes in, seamless 24/7 connected care across these different care levels, so that the data travels, the knowledge is generated by a connected care system, so that the patients and the staff can concentrate on their relationship and improving the outcomes. Now, that of course is not the reality. The reality today is that healthcare is fragmented and complex. And that comes with a cost. We see, of course, patient experience, as I mentioned, unpredictable health outcomes, staff dissatisfaction, higher cost of care, and all these parts of the healthcare system that do not talk to each other. It leads to a lot of waste. We see in some areas that more than 30% of cost are waste in the healthcare system. And some people say that healthcare is the last sector to get, if you like, professionalized and industrialized and standardized. Now, what are we learning from COVID? Because of course, this fragmentation of the healthcare system is not new. We've seen that, we realize that it needs to be fixed, but the urgency by which governments and health systems have been trying to fix it has not been there. And it's a little bit like a house in the sunshine. You don't notice that the roof is leaking until it starts raining and the water starts coming into the house. And then you suddenly see, oh, the roof is leaking, we need to fix it. And COVID-19 was like a house with a broken roof that suddenly got rained on and very, very clearly showed where the failings and the shortcomings were. Ill-equipped, not prepared for a pandemic, not properly trained, not properly staffed, no idea on how to redistribute patients or how to coordinate care. And of course, we saw that elective care and regular care collapsed. But we've also seen that some of the transformations in healthcare that started before COVID were accelerated during COVID, and that stands as hopeful. We see, of course, the move towards digital. Also in Poland, we see that everything moved to digital: shopping, eating, dating, education, healthcare, everything is really, really gone digital. Telehealth has made a real breakthrough. We've seen reimbursement systems change, that suddenly telehealth were possible because doctors didn't want to see patients that had COVID, and they had to resort to telehealth. And I'll come back to some more examples on that. But we've also seen an incredible movement and acceleration of innovation. Healthcare providers and innovators around the world were trying to find ways to make ventilators cheaper or CT scans, faster, and make sure that the algorithms, the artificial intelligence algorithms, would be developed to allow the algorithms to actually do a prediction or a diagnosis of the situation. And so too, at Philips, we have seen enormous numbers of innovations being accelerated and spurred by motivated people that wanted to contribute towards better healthcare systems. And we've seen the role of government change. Government is taking a more active role in national programs, but also in digitization. We saw it, of course, at the beginning that suddenly governments were taking up a new role in buying ventilators as a first response, or buying the vaccines, or buying allowing for other coordination. A role that many governments had led to the private sector and to the system to organize itself. But in these times of crisis, it was clear that governments need to show a stronger hand and need to develop the competences again to help coordinate, to help manage, and to build a system that deals with a pandemic and at the same time provides elective care. And we see that the business models are changing. Funnily enough, it's not funny actually, but strangely enough, a lot of healthcare providers and hospitals suffered during the COVID crisis because of the collapse of elective care. And they had to fire people. And the healthcare system became very prohibitively expensive. And there were no revenues. So that called for an acceleration of changing the business models, more flexible and adaptive healthcare capacity and partnerships. So too, at Philips, we've been accelerating partnerships to improve care, but reduce the risk and share the risk with hospitals around the world. Now, I'll give you a few examples of how we think in the next 3 years we'll see a focus on biomedical innovation, in particular in telehealth. Telehealth, as I already mentioned, really accelerated during COVID. At the bedside, also in tele-ICU and remote monitoring at home. I'll give you an interesting example. In the beginning, we saw a lot of ICUs populated with COVID patients. Now, COVID patients are infectious, contagious, and therefore every time a nurse had to walk into the patient room to take a temperature, to take a pulse, or look in the breathing rate, or check on the patient in general, they had to get dressed, do all their personal protection equipment. That took a lot of time, go into the room, take the vitals, and go out, disinfect, change again, and then move to the next patient. Time-consuming, tiring, and a waste. The simplest form of telecommunication was actually, interestingly enough, a baby phone. So we suddenly saw a surge in demand for baby phones, because you could put the baby phone next to the patient and then next to the nurse on the outside, and they could communicate and they could tell the vital signs and they could talk without having to change all the time and go into the room. That's the simplest form of telehealth, if you like, in the hospital. But of course, we are seeing more sophisticated telehealth, whereby the vital signs of the patients can be read remotely by connected devices. And as you see in the image, have a control center that can look at the patients, and the computer supports the nurse at the station to raise the alarms when a condition is deteriorating. Now, already we were able to predict when a patient would get a heart attack 4 hours before a nurse or a heart attack would actually happen, because of predictive analytics by using those vital signs. So we're now trying to see, can we actually predict whether a patient is going to develop symptoms for COVID 48 hours before they actually have the symptoms. And that's of course important, because not everybody has symptoms. Some of the symptoms are very subtle. So we're seeing more remote telehealth, tele-ICU capacity with smarter decision support tools that are based on the vital signs. On precision diagnosis, we've seen revolutionary improvements in the way CT, ultrasound, and X-ray are being used, and artificial intelligence plays an important role there. But we also see that all these image reports, digital pathology reports, blood reports need to be better managed in enterprise tools and enterprise imaging from different modalities, different brands, so that the information is being presented to the radiologist in a more concise, user-friendly and easy way, so they can spend the time on making the diagnosis and doing the interpretation, rather than processing all the imaging and trying to find switching between the different tools all the time to get the right images. Now, the third one, which I think is most important, is interoperability. Everything in the hospital will become digital. And so it is important that we understand what is the interoperability framework within the hospital, but also outside the hospital in our community, towards the patients, but also between hospitals at the national level. And I'll turn to an example in the next page. but I want to explain how important this is. We've seen, for example, in the United States and in Germany, that up to 3/4 of the recovery budget for the health system is spent on digital health. The realization that healthcare needs to be digitized is so strong in Germany, in the United States, the Netherlands, and other countries, the European Union, that they said up to 3/4 of your budget you're going to spend on digital health, digitizing health. Now, digitizing health is not just about digitizing what you already do today. It's about transforming and then digitizing. So interoperability is really, really important. And I'll give you an example of why that's important in the next one. During the COVID crisis in the Netherlands, a lot of the patients were clogging up the ICU beds, especially in the south of the Netherlands. And the hospitals had to redistribute the patients to other hospitals because of the shortage of the ICU capacity. And what happened is that when a patient, for example, from Eindhoven in the south of the Netherlands would be transferred 200 kilometers further to Groningen, is that, of course, the hospital that would receive the patient did not know what kind of patient they were getting, did not know their history, their conditions, their blood type, etc. And the electronic health records were not interoperable. So Groningen could not access the Eindhoven portal and actually see what patients they were receiving and take precautions. So what happened is that the hospital in Eindhoven would just print out the electronic health record, put it in a folder and ship that with the patient in the ambulance to the hospital. Now, the first thing that would happen when the patient was received in the other hospital for the ICU is they would throw away the electronic health record because it was contagious. It traveled with the patient. It's dangerous. So without actually looking into the paper, they threw it away. And so very quickly, the hospital said, we need a solution to this. And together, in partnership with the government and Philips, we very quickly came to the decision that the more than 70 hospitals in the Netherlands would have to access each other's electronic health records to understand what kind of ICU patients they were receiving so they could take the proper precautions and apply the proper care. So within 2 weeks, we created a portal to allow everybody to access each other's electronic health records in a safe and secure way through proper authentication. And that interoperability and that portal came about in 2 weeks' time. Pre-COVID, it would have taken about 3 years to negotiate that. So we see that some of these transformations are really accelerated, and we're hoping that after COVID, that will continue. But it is not just the interoperability and digitization, the telehealth, and the precision diagnostics that we need to change. We need to rethink our hospitals and our health system entirely. This is the time to think about what is the impact of our healthcare system, how does it work, and how can we reshape it. And I want to show you a very short presentation video on some of the ideas in our design organization that we have to transform healthcare. And that hopefully that will get you to think about the healthcare system in the coming 10 years. So, hoping that this works.
Have you ever wondered, how will healthcare look like in 2030? In a decade from now, we will probably live in a world with infinite access to healthcare. Anyone can receive care at the snap of their fingers. And how, you may ask? Well, all of this will be enabled by one simple but fundamental shift in technology: autonomous mobility. Today we see a continuing and concerning trend of cities building more and more hospitals to meet the demand of their growing population. This may solve the problem for now, but it is incredibly expensive and not at all sustainable for the long haul. So think about this. In 2030, healthcare is decentralized. Hospitals will only consist of crucial elements that require patients to be on site. All other functions will be redistributed and made entirely mobile in a network of hyper-connected autonomous vehicles. So instead of you going to the hospital, how about the hospital going to you?
So I hope you could hear the sound with that. that a yes?
Yes, it's okay.
Yeah, okay, good. So the operative word here is decentralized healthcare. And I know that a lot of countries are reacting to the crisis by building more hospitals. But hospital infrastructure is there for the next 30 to 50 years. And this is the time to rethink the future of healthcare. And if healthcare is properly connected and the patient is put central, then the hospital of the future, it really becomes a network of flexible capacity. Definitely after the pandemic, it's got to be flexible capacity and connected by a single digital infrastructure. One of the former CEOs of one of the biggest hospital organization in the United States told me once, they said, look, I have many, many hospitals around the country. And in hindsight, if I could start all over again, I would demolish all the hospitals and I'd start again building everything around my mobile phone. And then maybe I still have some hospitals here or there, but it would look completely different. So what would it look like in a connected infrastructure where all the information talks to each other? It's a little bit like this. Now, is this futuristic? No. A number of these things already exist today. And I'd like to give you some examples because that may also help you to think about how do we not only rebuild the healthcare system after COVID, but completely transform the healthcare system so it is future-proof not only for 2030, but way, way beyond that. First example is, how do you enter the healthcare system? This is an example of a virtual care station for veterans in the United States. Now, as you know, veterans in the US are often living outside the city. They live outside the city. They are far away from a nearest hospital, sometimes as far as 5 hours drive. So access to care is a big problem. And so the Veteran Affairs Department of the US has developed a project together with Philips and other partners to see how could they bring telehealth closer to home, address the issue that these veterans often don't have proper internet connection. They don't like to travel. And if they can't travel, because it's expensive and it takes time consuming and they don't have the supporting family to help them, then they often don't enter the healthcare system until it's too late and the ambulance has to make an expensive intervention. So these veterans come together in their veteran community halls in the villages around the United States. And that's where they feel safe, they feel comfortable. So we created private rooms with televideo capabilities and some technology to take vital signs, where veterans could make an appointment with a nurse or a doctor that sits remotely and at least talk about mental problems, nutrition advice, well-being, vital signs, cardiovascular conditions, etc. And take stock of the patient and how they're doing longitudinal, so periodically check in. So they could also track and trace how they're evolving. And so for those high-risk patients that are deteriorating, they could actually help them to say, well, now you need to come to the hospital because it's necessary. And this way, avoid unnecessary travel to hospitals and remotely manage and enable the patients to manage their healthcare themselves. Now that's in the US, but we see this in Japan and we see this in other areas. Some of them are using mobile technologies and others are not. I'm trying to see why. Oh, there we go. Another example is from the Netherlands. In Bernhoven. And Bernhoven is actually the epicenter of our COVID pandemic. That's where it all started. But before it started there, we already engaged in a partnership through Vital Health, Philips Vital Health, which is a patient-reported outcome measurement solution, to coordinate the care for cardiovascular patients. Now, as you know, cardiovascular patients are often have mortality rates that are higher than oncology patients, and their condition changes every day. It could be a change in the weather that requires an adjustment of their peeing medicine. It could be a change, the fact that they've eaten something heavy and they feel differently. And it is very difficult as a caregiver, especially as a cardiologist, to monitor your patients remotely and to understand what is weather related or what is really a deterioration. So we developed a care coordination platform where the cardiologist and the general practitioner in the community and the patient would all share information. Patients can log on, add some vital signs, they can get access to their data, they could get educated, and they could see contact with the caregivers. And what is allowed is an optimal care coordination between self-empowered patients, the general practitioner, which is the lowest cost in the care providers, and the cardiologist. It also led to fewer hospital appointments because we could anticipate a worsening of the patients and take corrective measures by the GP. And finally, it led to improved quality of life of the patients. Now, these kind of models, whereby we have virtual care coordinated across different care settings, we believe is the future for any chronic condition, but also for acute, as we've seen with COVID. Virtual care is also important for emergency care. So we see that if we are trying to imagine that stroke is one of the most complicated and expensive conditions that really require very, very fast interventions, it's important that when a stroke patient is identified and the ambulance goes, is that we immediately start to do some exams. Now that's now possible, the vital health, of course, but also you see an ultrasound here with a react capability. You can see two people in the screen watching over a nurse sitting in the ambulance and doing an exam, so that the radiologist and the cardiologist can immediately see what's going on. So while the patient is transferred and transferred through an ambulance, the data is transferred real time so that the hospital can take preparations and reduce the time to the cath lab and the intervention to actually take out the blood clot. All of this is AI supported and AI enabled. Now, if you can do this, if you can connect the patient data from the place where they have the stroke all the way into the cath lab, you can also transform the way you organize. So we've done this with the Estonian government, where we looked with the insurance companies and the government and the hospitals to see where is the biggest at-risk population for stroke patients. And how do we then reorganize and anticipate? And how do we target the risk population to already start to minimize their risk and change the behavioral changes? And how do we then reorganize the patient flow that if people do get stroke, that we can pick them up quickly, we reduce the time to needle to like 6 minutes if possible, or at least resuscitation, and I think it's 2-hour reduction, and reorganize also the care afterwards so that we can continue to support them in the revalidation. Now, those are all the challenges that I do want to give you in my last slide. An innovation challenge perhaps also for the students and the partners for the coming 2 years. How do we improve treatment of IHD patients in Poland and cardiovascular conditions, knowing that the market has many, many unmet needs? In Poland, we know that cardiovascular disease leads to about 220,000 new patients, more than 11% mortality, and 700,000 patients at risk. But only 1 in 22 patients actually benefit from rehabilitation, and only 4% of the budget is spent on medical rehabilitation. Patients often travel very far to hospitals to get better treatment, or maybe to refer up to specialist hospitals. But still, 35% of the patients are re-hospitalized within 30 days. So if we look at the picture below, a patient that has a cardiovascular condition could choose to walk into a general practitioner's office, or very often not do anything until it's too late, and then immediately get referred to the ambulatory care. But in the general practitioner we see that we see that there is often no or limited digitization. So when the GP refers the patient to the hospital, there the intake starts all over again, the description of the symptoms, maybe some diagnosis. But due to limited digitization, any referral to, for example, ambulatory care will lead to having to do the same thing again. And all the time there's travel, there's waiting, there's making appointments, there's redoing the diagnosis. So how can we rethink this? How can we make sure that the patient does not do nothing, but is supported remotely, and that they immediately enter the healthcare system at the right place to receive the right care? So we believe on the right-hand side, the Philips integrated solution for cardiovascular diseases in redefining a referral mechanism that is able to quickly detect everyone. We also need to then leverage technology expertise to drive better diagnosis, better decision support, and hence optimize the revascularization rate and reduce the cost for hospital operations, not only in the hospital, but across the care system at all levels. Because there are some perverse incentives that will increase the cost at one place and reduce it in the other. So we need to look at the healthcare system. And we need to create easily accessible and comfortable in-home solutions for the patients to give them access to professional rehabilitation remotely, preferably remotely. Poland is a big country. We don't want everybody to travel all the time. Now, this is possible with some innovation. And it is also possible because in Europe, we have a Gaia-X project. And Gaia-X is the vision of initially Germany and France, but now it's become European through Ursula von der Leyen, to create a European cloud infrastructure. And on that cloud infrastructure, we need to create safe data spaces to safely and securely exchange data where appropriately within the region, between the regions, in the country, and between the countries, to improve research, to improve provider-to-provider collaboration, and to finally, most importantly, improve provider-to-patient communication. Now, the European Commission has said that in 2021, they will create a European health data space. And on that European health data space, we will see virtual care services being offered and developed. And those will transform healthcare across Europe. And hopefully that will inspire innovations to be adopted outside of Europe based on European competitiveness. And I wish the biomedical faculty of Professor Krik and Rector Menschik all the best, also with your students, to be able to innovate in good health, with good fortune, and turn this risk into an opportunity to collaborate in new ways with your partners. And we would love to be part of that. So that we continue to innovate, celebrate, and collaborate in the coming decade, putting the patient-centric in a connected care delivery system that is seamlessly connected for better outcomes. I wish you all the best, and thank you very much for having me.
Rector, please switch on microphone.
Yes, sorry, I forgot that microphone is switched off. Jan Willem, thank you very much for your very interesting presentation and the global approach to the healthcare system and its transformation. A very advanced solution requiring a coherent IT systems, enabling monitoring, data processing, and diagnosis support, and also a very good interface to the patients. It means application, mobile applications, etc., etc. So we have still a few minutes for the questions. Are there any questions to the presentation? Very, very interesting and inspiring presentation.
Thank you, President Scheijgrond, for your very interesting presentation. I'm really impressed. So Philips have so high knowledge about Polish healthcare system, and we think about Philips as a company which produce devices, which produce apparatus, but the presentation proves so management and organization of the healthcare system generally is a dominant activity of the Philips company. And I would like to ask you the question about the remote technology for the taking care patients with COVID-19. Do you have implemented some special devices for the care of the patients?
Yes. We know that technology is 10% of the transformation. 90% is behavioral management transformation. So it's very important as a technology company to realize that you're only a small part of the transformation. So that's why we've really looked at transformation skills and how you transform healthcare systems. Now, towards the remote technologies and COVID, we saw a big, in the beginning, and I'm sure the same was in Poland, we saw many patients entering the hospital thinking that they had COVID symptoms. And especially in the upcoming flu period, we will see many people which have a cold or which have a temperature or may have the normal flu go into the hospital thinking that they have COVID. And so it's really, really important that we keep those 90% of the patients that do not have COVID out of the hospital so that we can focus on the 10% that might have COVID. And we developed a patient-reported outcome measurement tool with a number of hospitals in the Netherlands, where we looked at how can we help patients to monitor their own situation, their vital health, their temperature, there's some of the other symptoms. Are they losing their taste and are they losing their smell, and vomiting, etc., which they could enter, and a computer could then automatically identify the high-risk patients that could have COVID. So it segregated high risk from lower risk. The lower risk would get a call and say, don't worry. So it's very important that we had the personal intervention, but we could keep them at home and we could convince them not to come to the hospital. So you're fine, but keep monitoring yourself every day. And if the situation changes, our computer will pick it up. The high-risk patients, we could then segregate again further to understand, to give them an advice, to keep them at home and keep monitoring the symptoms. And for those that we saw that were deteriorating day by day, we could actually call them into the hospital. This meant that the doctors could focus 100% on diagnosed patients, and they would come to the hospital, so the hospital system could cope. And at the same time, the patients that were at home knew that they were being taken care of, that they're being watched, and you could actually help them by taking away their fears. And they were actually pleased that they did not have to come to the hospital, and they still felt watched over. So those are the technologies, very simple telehealth solutions, but you keep most of the patients out. 90% can be done by students or nurses who are being educated to do the phone calls, and only less than 10% are being seen by the doctor. And in addition, we saw technology developed in the hospital for EICUs and control rooms. But one of the things we saw was ultrasound. In the beginning of the crisis, people would go into a CT scan because that was the best diagnostics. But to get a COVID patient into a CT scan, especially a very sick COVID patient, is sometimes not possible. You can't move them. You want to keep them in the bed. Or if the patient could be moved, it would take 3 or 4 people to get the patient into the CT scanner. And then everybody had to be decontaminated. The entire room had to be decontaminated. So it took a lot of time. So as there were more patients in the system, we saw that CT was no longer possible. It just took too much time, too cumbersome, too many people involved to actually get them into the CT scanner. So we saw that it was changing to mobile X-ray close to the bedside, and also mobile ultrasound. And it's there where we were working with American doctors that we could see that the coagulation of blood clots was taking place in the heart and in the brains due to COVID. And we could actually see it in the ultrasound. We could see at the bedside ultrasound, handheld ultrasound, this is happening. Coagulations are forming as the situation worsens. And that led, as you all know, to the effect that we were adding blood thinners to COVID patients to reduce blood clots, because I think 50% of the death in the ICUs were due to cardiovascular conditions, not due to COVID, but cardiovascular conditions that were a result of the COVID virus. So yes, a lot of technology, remote in the hospital, remote at home.
Thank you very much. Are there any questions?
Yep. First of all, thank you, Mr. President, for your visionary presentation. I like it a lot, and I will explain why. But before I make it, I apologize for my introduction, because at the beginning I made a mistake that our company is working in the field of hospitality. Of course, we are very hospitable for our patients, but we are working in the field of hospital care, of course. But now let me go to I would like to comment your presentation. First of all, as I said, congratulations. I think that Poland is a very good market for Philips, because we already have introduced some of your ideas into real life practice. For example, decentralized hospitals. I like this idea a lot, because we know that if we have a serious medical problem, condition, we need to transfer the patient for many kilometers to the large university hospitals. And in 2000, our company has opened the first small hospitals to treat acute myocardial infarction, and now we are the largest network of private hospitals that can treat myocardial infarction in relatively small clinical centers and provide fast care to our patients. So I think that I would go the same way as Philips suggests. So build small hospitals that are really decentralized. The second thing is telehealth. We already use the telehealth systems. We have a Center for Cardiac Monitoring in our company, and we are providing care to our patients for more than 5 years. Now we use the same technology not to only monitor heart rhythm disturbances and other problems, but also to give advices to the patients that are suspected of COVID. So I think it's the future of medicine. And also, for more than 10 years, we are using the LifeNet system in our hospitals. So it means that somebody from ambulance can send us the ECG signal directly to the hospital. We can consult by phone the ECG and then decide what to do. So this is the same kind of coordination. So I believe that we are going the same way, but we definitely need to improve the system, give more technologies like CT for image that we could send to other hospitals and places. Of course, in terms of COVID prevention and providing care to the patient, we also designed some kinds of containers that will be ready in the next few weeks. This was done with the Alvo Medical, the Polish company that produced operating theaters, and we designed everything what you've said. So we will have a special container which will stand next to the hospital. We will have the audio and video systems that allows us to communicate with the patient, because every time we need to change to put on the scrubs to talk with the patient is very unpractical. So we need to cooperate with Philips and other companies to bring better and faster care for the patient. But two things, short things, are the sophisticated IT systems, a lack of coordination. I believe that these are the two fields for Philips to work on, because many physicians complain of too complicated IT systems. Sometimes it takes longer for us to fill out the patient data than to write something on the paper. So we need to really work on that. And lack of coordination, it was shown by our, unfortunately, government. So you heard a lot of opinions about COVID pandemic of many experts on the internet, on the TV set, but I felt that there was lack of coordination between those experts and our government. So those two parts of medical world need to cooperate better. They need to use the IT systems, they need to organize the conferences, online conferences, they need to communicate and build a better strategy to fight the COVID. So that were my impressions on your talk. I'm really impressed, and I'm glad that you are cooperating with University of Technology. I hope we'll also be the part of this system. Thank you.
Thank you. Maybe I can react quickly.
Oh yes, of course, please.
So I recognize all the things, and I congratulate you on having done so many of those elements already. And as I showed in my vision, and vision for Philips of a decentralized healthcare system, is that a lot of these building blocks are already there. But as you say, to make it complete, we need to make sure that IT is easier for the patient and for the doctor, the caregiver. As I said, the patient satisfaction and the staff satisfaction are important. A lot of the staff is not satisfied in having to enter all the data all the time. We always say, look, high tech for high touch. So you can use high technology or IT technology, but it should enable the high touch, because healthcare is a touch profession. The doctor and the patient need to look each other in the eyes and be concentrated on each other. And the technology needs to be built around that to facilitate that, to spend, if you have a 7 minute or a 10-minute consultation with the patient, you shouldn't spend 8 minutes on typing stuff in your computer. I mean, I've experienced that myself, the doctor not looking at you, but looking at a screen. Very frustrating for both the patient and the doctor. So this IT coordination, and knowing that a hospital may have between 200 and 500 different IT applications that don't talk to each other, is very frustrating. So yes, that coordination, that IT is very important. And this requires co-creation, because you need it at the hospital and you need it at the regional level. And so Professor Gzik was telling me that there are about 170 hospitals in Śląsk. How do we have the 170 hospitals and the clinics and the GPs and the physiotherapists and the psychologists and everybody else in a system whereby we all look at how do we envision that future of that system to look like in 10 years? And I think that's so important that we have the government together with the private sector and the private hospitals and the public hospitals and the academia working together to co-create a vision for what the future could look like in 2030 when we celebrate the 20th anniversary, and then back channel and create a roadmap how we get there. And even, we as Philips, we don't have the answer to all the questions, but we do know that the ingredients to all the answers is that we sit together in the room, for days and weeks, facilitated by a neutral broker, a trusted broker, and very often academia is that neutral and trusted broker, to agree on the way forward. And we've seen that wherever you do that, whether that's in China or US or Poland or Estonia, the Netherlands, that way of working, of bringing everybody together around a common vision and then defining the steps to get there, that works. And so we look forward to working with you and all of you there. And there's a role to play, whether you are a first year student or whether you're a rector of all the universities. I think there's true value in that, and I look forward to building on your expertise, because you have that expertise already apart in the local context, and to see how we can build upon that.
Thank you very much again. Rector Mężyk apologized because he has another conference. He was invited by ministry to conference about pandemic COVID, and President Scheijgrond, we would like to thank you again for the interesting presentation and discussion. And unfortunately, the remote mode of the conference doesn't allow to invite other audience to asking questions. That's why we have to thank you again and start next presentation. Thank you again, Jan Willem. Thank you. I use the opportunity to thank you for your personal engagement in my visit organization in Eindhoven last month. Thank you again. And I hope we will see you soon. Thank you so much.
Thank you. Thank you. Good luck with the conference. Thanks.
Thanks. Now I would like to ask Professor Milewski to introduce next lecturer, keynote lecture, Professor Bochenek, and next presentation. Professor, please.
So I have good news to our audience, because now we are moving from very interesting lecture to another very interesting lecture, and this lecture will be presented by my mentor and the founder of American Heart of Poland, and most importantly, everybody knows Professor Bochenek because he was one of the pioneers of cardiac surgery in Poland. So coming back from the history, now he will talk about the future of cardiology and cardiac surgery. Professor Bochenek, now is your time. Can you hear us? Yes.
Yes, I can hear you. Sorry, I was not informed that the conference is English, but I have some slides in Polish, but I will try in my broken English just to share my impression how the cardiac surgery has changed during my presence in this business. So I will try now to have my lecture here. Do you see me?
Yes, we can see you. We don't see your slides yet.
Okay. Do you see my slides now?
Not yet.
Not yet. Now?
Now we can see it. Yes, it's
yes. So just in my short talk, I'm going to tell you about my nearly 40 years history in cardiac surgery and how this cardiac surgery will look in the 21st century. So just, sorry. Okay. So I think it is very important that not the strongest who survive, that says the Darwin, but not the most intelligent, but those who are most responsive to change. And everything is changing. During my life, I've seen that everything is changing in my specialty. So for example, just look, the most difficult problem was how to open the heart and not to lose the blood. So the first operation, and I remember such an operation that was in the 1970, even in Poland, that was the operation in hypothermia. So what can you do in hypothermia? You can stop the heart for about 7 to 9 minutes, and you can just close the small defects. So we are closing the atrial septal defect during the mid hypothermia. That was the hypothermia about 29 centigrade. So you see that the patient is cooled here. Then they move the patient to the operating table, and we need that time we need a very fast cardiac surgeons who were able to open the right atrium and very fast close the atrial septal defect. Now everything obviously has changed, and we are not performing such operation because the cardiology has replaced us. But that was only for the short operation. But if you want to do the more complicated operation, you have to stop the heart for the longer time. So since they developed the pump oxygenator and heart-lung machine, we were not able to do a very complicated operation. And I was in the Mayo Clinic, and I've seen the first clinical pump oxygenator. You see, it was a really big machine. Comparing now to this oxygenator we have, and you will see for the next slide, it looks very complicated. So that means that we need a lot of blood pumped into this reservoir. This reservoir was filled with the special screens, and we put the oxygen here. Then we have to take the blood and use the special pump to move to the heart. So since the development of heart-lung machine, we are not able to do such a complicated operation. I remember that in Politechnika Śląska, together with Professor Antoszewski, we developed they developed the first heart-lung machine. And I remember in 1975, the first operation performed on a heart-lung machine developed in Politechnika Śląska. So that's the oxygenator. But look, that was how it was looking, the first heart-lung machine. Extremely big oxygenator, pumping the blood to the aorta. And now look, thanks the technology and thanks the people who are engineers, now we have such an oxygenator. It's completely, that's completely changed. It's about 10, 25 centimeters, small machine with many capillaries where they pump the blood, and the blood has no contact with this, and the oxygen has no contact with the blood, which is much safer for the patient. So that's the development and technology. That's the first heart transplant in Katowice. You see here Professor Religa, and you see the operating theater, how it looks like. But then it has changed everything, you know. We've changed the heart lung machine, which you can see here on this picture, and operating theater as well. So a lot of systems which are developed by the engineers are helping us to keep the patient more safe. I remember the first operation, we didn't have even the proper measurement of blood pressure. We even don't have a proper measure of venous pressure. It was just measured by the very simple machine. Now it's completely different. We can monitor nearly every element of our vital signs. So, and the operating theater has changed as well. Look, this is our new operating theater in Bielsko, in our Department of American Heart of Poland, but completely different. So here, there is the place for anesthetist, but the most important is that this is a hybrid operating theater. So that means that in this operating theater, we can work together with our cardiologists. Part of the treatment can do the cardiac surgeons, but the other part can do the cardiologists. So that's the real change. So the hybrid operation. Why we need now such a hybrid operation? We need it because the patient demands fast recovery, no pain, no scar, and it is not so easy to do by the cardiac surgeons, which are rather used to do the big scars. They always say that the big surgeon, the big scars. Now it's completely different, small scars and the very good cardiac surgeon. So you see, it looks different, and everything has changed in nearly 50 years. The technology has completely changed. So you can compare it like driving with the Trabant car, and now we are driving with Audi or Mercedes. And the most changes in the cardiac surgery and the big development is thanks to the imaging. I remember the first operation of aortic aneurysm when we know only that there is aortic aneurysm. Now we can, thanks to the imagination, we can see much more, and the operation are different and completely safe. It's like in 1914, there was a drawing how somebody has imagined how the operating theater will look in 2000, and he was very near, because look, thanks to introducing the computer, thanks to introducing the robotic, we are able now to do better surgery with low scar. It's not so easy because the robotic systems in cardiac surgery are not perfect, and I think that we will need another 10 or 20 years to develop the different instruments. But on the basis of aortic valve, I would like to show you how everything is changing. You see, the aortic valve is here, so it's not too easy is not accessible without opening the heart. And I was thinking that is not accessible for many, many years, but this has changed as well. How it has changed. Look, this is aortic valve. The aortic valve, now we have a not pandemic, but epidemic of aortic valve stenosis. And you see that the valve, there are different types of valve, tricuspid valve, bicuspid valve, and such a valve do not work properly. So what is the method of treatment? The method of treatment is only to replace. And I remember when I was a young cardiac surgeon in 1974, my Professor Paligoda took me to the hotel forum to Warsaw, and there was a meeting with Albert Starr. He was inventor of the aortic valve. And look, it's very easy. That it's a ball in the cage and it's going up and down. But there was a lot of problems with this because of the problem that the structure here sometimes disrupted and the ball just leave the cage. So there was several attempts how to improve the valve. And you see, these are disc valve and these are two disc valve. The most important is the flow. All the inventors who invented the valves wanted to have a central flow, but to have a central flow, you have just, you have to be careful because it's only central flow, the valve never closed, so it's very difficult. Here you can see how looks the other valve, which is not mechanical, is a tissue valve. Why there is so many valves? Why we don't put mechanical valve to every patient? Because not any valve is now still perfect. The tissue valve are very good, but they do not last longer than 12 or 15 years, even the best valve. The mechanical valve, they last forever, but they need, the patient need a lot of anticoagulation. So far we don't have a perfect valve. You see, many companies produce different valve and they differs only because of the material they use for the leaflets. There are porcine leaflet, bovine, and different leaflets. Obviously, in heart we don't have a ring, so we are trying to develop the valve without such a ring. We call it stent. You know, it's in valve we don't have in our heart we don't have any ring. So when we put such a valve, we are adding a ring to the orifice. So the orifice cannot be as wide as we really wish. So we thought that maybe with the valve without the ring will be better. But we have to deal now with rather with the older patient. So this older patient needs a fast operation. The normal open heart operation, for example, the explanting and implanting the valve, that we need about 40 to 50 minutes of stopping the heart. But in such a systems which are self-deployment valve, we need only 10 or 15 minutes. It's, as I said, there is still no perfect valve. And even with this valve, we have to put the patient on an extracorporeal circulation. We have to put the patient, we have to open the chest. But now we are dealing with the very old people. Sometimes they are perfectly in perfect health, but only have the problem with the valve. And such a patient, very fragile patient, sometimes there was a problem with opening the chest because such a big opening the chest is a problem with the healing. So I just wanted to show how is looking normal open heart surgery. So first was cutting the chest, then opening the chest, opening the aorta. So you see here, there is the cannula for extracorporeal circulation, another cannula for the aortic, the blood oxygenated blood is delivering through this cannula, but we can open the heart without any blood inside, and we can exchange the valve. So it looks like this. We put some stitches, measuring the valve and putting the valve. And this is, for example, tissue valve in aorta. It like this. Then we have to cut everything, close, and this is a scar. And it looks perfect if you are in a good health. But for the very old people, and now we are having epidemic of older people. Our society is older and older, and they have a problem with the valve. Such a scar is a big problem. So what we can do? We can start together with our cardiologists, and thanks to the technology, with implementation the valve through the apex of the heart. And you will see that. This is a short, I hope we'll have a short video. That was the first idea, that maybe we don't have to open the chest through the sternotomy. We don't need to put the patient on extracorporeal circulation, but together with our cardiologists in our hybrid room. That's why we need a hybrid room, thanks to people who developed the beautiful X-ray and visualization. Together with cardiologists, we can implant the valve, you see, through the apex. And that was the first step. You will see there's a balloon expanding the valve. And now we'll put the valve. Here. Through this catheter. But you see, it's still the operation. It's still, we still need a cardiac surgeon. We have to open the fragile apex, which is with the enemy of the surgeon, and it's always bleeding. And thanks to the technology, they developed the other, this is this valve, oh sorry, this is this valve we can introduce into the patient through the cannulas, different valve, as you see, there is no perfect valve, and possibility of introducing this valve through the femoral artery. Now, because of the sometimes the problems with the introducing through the femoral artery, we can introduce valve through the carotid artery as well. But you see, that is possible. That is possible. When I first time saw the experiment with such a valve, I thought that the people who are trying to work on this topic, that they are crazy, because there is a lot of calcium, because there is a lot of problems. As a surgeon, we have to cut the calcium. We have to put stitches. The stitches always sometimes are not perfect because of this calcium. So, but it is possible. And now in our department, we are doing more than 100 such a procedure, and obviously it's not enough, but we are trying to do more and more. How the cardiac surgery is changing? Mainly that we are going through the minimalization. We are trying to get the cardiologist, and we'll never do only the small hole, but we can change everything. For example, in mitral valve, We don't have to open the sternum. We can do it with the use of endoscope. We can repair the valve, not only to replace, we can repair the valve, and we can keep the patient in a very good condition without any artificial valve in the heart. So you can see, for example, here for such a small incision, we can get into the right atrium. Obviously, we still need extracorporeal circulation because we have to stop the heart. But we can open the right atrium, and we can replace or repair the valve through such an incision. So minimalization, you see, not big scar, but small scar, not replacing the valve, but repairing the valve. We can put the artificial cordy into the valve. We can put a special ring, and everything is for the benefit of the patient, that the patient do not need replacing the valve. So what is the future? The future probably, but it is rather a long future, is going again with co-working with the cardiologist. So here you see different instruments where together with the cardiology we can change the sinus, we can do the direct annuloplasty, or we can do even the valve replacement. There is many trials now working on the valve we can replace without opening the chest. The first in human experience was in 2014, but this method is still on the early stage. I'm not going to speak about the cardiology, but I have to mention that about 20 years ago, the main number of operations, the biggest number of operations were coronary artery surgery. Now, because of the development of cardiology, stents, and visualization and possibility of working without opening the chest, most of our patients now belongs to the cardiologists. They can put the stents. As you know, these are stent, angioplasty. I'm not going to show it, but even the cardiac surgery has to change as well. We know that that for the coronary artery bypass, we don't still have the perfect artificial vessel. The best for us is the left internal thoracic artery, but if you want to harvest it, so we have to open the chest, but not now. Together with our team and the people from France, we developed the method of ECAP surgery, and that was the first such operation we performed about 15 years ago, not opening the chest, harvesting the internal mammary artery and connecting this internal mammary artery directly to LAD. Maybe in future the robots, but frankly saying, I'm not thinking about the robots. I have to say that in the cardiac, in the coronary artery surgery, we never give up, PCI or cabbage. We are nearly swollen by this big bird, but we are still fighting. So far, thank you very much. And I think that you see how the cardiac surgery will develop in the future. Just minimize the incision, trying to help patient for the fast recovery. And I think that the future is in the cooperation with the technicians, cardiologists, and cardiac surgeons. Thank you very much.
Thank you very much.
Thank you.
Thank you very much, Professor, for your very interesting presentation. Let me to welcome, just a few minutes ago, join us the mayor of Zabrze City, Małgorzata Majka-Szulik. Welcome, the president. I got information that joined us the vice rector of Silesian University of Technology, Professor Marek Pawełczyk. Welcome, Rector. Now we have time for discussion, for some questions to Professor Bochenek. Professor, I think so we shouldn't convince generally people, so technology play a very important role in medicine in 21st medicine century. But I would like to ask you the question about the role of an engineer or engineers in your operating theater. Do you have support from any engineers during operations?
Obviously, it's very important that we need the engineers and we need the technician. Could you imagine that we have to move our hybrid room without the technician, without engineers? We need the engineers to run the Harlang machine, and definitely we need the technicians who are helping us during the operation. We cannot work without the technician, I have to say.
Thank you, Professor. But why I'm asking about? Because since 2015, we together with deans representing different universities where biomedical engineering direction is for students, we try to convince ministry about medical engineer legacy to work in hospitals. It is still not good solved in our healthcare system. That
they do not understand it, that everything has changed. There is not now that the surgeon have the sucker, forceps and knife. Now we need a lot of different instruments. We need the instrument just to treat the atrial fibrillation. Somebody has to see how it is response, There is a lot of different systems on our operating system, just monitoring the brain, monitoring the heart. So if you are concentrated on operation, you cannot think about the most of the instruments which are working. You have to be sure that somebody has the look on this and know that everything is okay, and you can work on your problem, to develop your problem, not to develop the problem that this or that is not working. It's very annoying when you have such a problem, and unfortunately I have to say that nobody understands this problem, that we need a very well-trained technician or engineers in our operating theaters.
Thank you for your opinion, Professor. When Professor Zembala was a Ministry of Healthcare System, he invited us to present problem of engineers in hospitals, and unfortunately we still don't solve the problem, and I hope soon we could change the situation, because as you said, engineers in hospitals play a very important role, especially that we have more and more implemented technology, and generally future medicine, personal medicine demands technology development. And without engineers who will control the devices and apparatus, it will be not optimal system in our hospitals. Thank you, Professor.
Yeah, I would like to comment also because I'm doing structural heart interventions in Bielsko, in our hospital, and I think that there are two crucial things: that we don't have IT guy on site. Because I mentioned previously that one of the problem is sophisticated IT systems that we need to work as a physicians. So we really need to have a support from the IT system on site. And the second thing is the biomedical engineering. Why? Because operation is not about the operation, it's about the pre-operation period. Just to prepare the imaging. For example, now we are using fusion techniques. We can combine, for example, echo with CT and with angiogram. So it's really sophisticated process.
For example, if you really want to implement the minimal invasive valve without opening the chest, especially mitral valve, we'll need a lot of instruments, a lot of possibilities comparing echo, CT scan, and radiology image. So I think that without the technology, we were not able to do that.
And physicians do not have the knowledge about the imaging, and they don't have time to prepare the fusion of the images. That should be done by engineers.
So for example, look at this simple situation. Many years ago, the Harlang machine was running by the doctor. You know, now it's running by the technician, and they are much better prepared to run this than the doctor, because the doctor was thinking, for example, the cardiac surgeon. One of our cardiac surgeons was just sending to run the Harlang machine, just between the other activities, you know. So now there are people who are specially devoted to this, and you really have a great help from them, because they know everything about how to run Harlang machine in a different situation, in a simple valve operation, or difficult hypothermia, or replacing the arch of the aorta. It's another knowledge. And there is perfusionists, and the perfusionists are technicians, you know. So we probably in the future will need the technician to the other systems as well.
So let's bring medical engineers to our hospitals, just to help patients make the procedure safer.
Obviously, the people who are running from the financial point, they will say that we don't have the money, and that's the problem.
But let's convince the government to bring them.
Yes, the government wishes.
Exactly. Not on our hospital level, but rather on the government level.
Thank you.
Thank you.
Thank you, Professor, very much for the discussion, for your presentation. And now I would like to introduce next lecturer, keynote lecturer, Professor Roman Major. Professor Major, representing Institute of Metallurgii and Material Science of Polish Academy of Science. And the title of the presentation is Nanostructural Materials for Implants and Cardiovascular Biomedical Devices. Professor, take the floor.
Thank you very much for the kind introduction. Let me start the presentation right now. During my presentation, during my lecture, I would like to focus on the most important project which were executed together with our coworkers, the closest coworkers. So just at the beginning of my lecture, I would like to underline that the results which would be presented here during my lecture are the results of the whole group of interdisciplinary group. Our adventure with biomaterials started several years ago with the closest cooperation with the Foundation of Cardiac Surgery Development in Zabrze, mostly dedicated for new generation of materials dedicated for heart assist system. Starting from this time, we were trying to develop new materials, much more sophisticated, based mostly on several different projects, basic research projects, as well as applied research project. But maybe I would, at the beginning of my lecture, I would come back to the past a bit. I would mention about some history of why development of the technique in medicine is so important. Especially in the heart assist system. Heart assist system maybe is a relatively old topic, so we can find some information even in 1982 when Roland Ross has elaborated quite interesting description. It was a bit, I would say, scientific, maybe some dream associated with heart assist system. He has developed a real simple history about the future, how the future could look like, especially which was dedicated with the heart assist system. The next date, which was associated with the, I would say, milestone, which was associated with the development of heart assist system, could be found in 1928, where we can find newly much more sophisticated machine developed by Henry Dale and Edgar Schuster. This system was dedicated to restore total circulation of the heartless animals. Next milestone is dated for 1935, where Charles Lindbergh also is well-known person because he thrown over Atlantic Ocean. He has also developed a quite interesting device, which was he wanted to implement to the heart assist system. Unfortunately, his system was not implemented to the clinics. It was presented during one Hollywood movie. Unfortunately, in practice, this system was not introduced. Next, 1937, Vladimir Demichov has also developed some prototype of the heart assist system, but the real milestone, important activity has started just after the conference organized by American Society for Artificial International Organs, where real design of artificial organs, artificial heart appeared. So in 1957, Wilhelm Kloff, together with his student Robert Jarvik, developed artificial heart made of plastic. Robert Jarvik has never finished any studies, but he was actually so open-minded that Wilhelm Kloff decided to employ him in his lab. Fortunately, this cooperation was extremely fruitful, and both they have developed quite interesting solutions. I would like to also mention about a very important date, 1963. There's a first patent which was elaborated by Paul Winchell. He has he didn't have any medical, he didn't finish any medical studies. He was only inventor. He was also an artist, playing even the role in cartoons. But his proposition, his idea were so important and so intelligent that even Michael Debekay, together with his student Lyotta, decided to take some solutions from this patent, of course, cooperating with Paul Winchell. And the last important thing, there's a quarrel between the Michael Debekay and Dr. Denton Cooley. Both have developed artificial heart, but who has developed the first? There's still there's discussion in the history of artificial organs. But what happened? What was going on in our country? Of course, we have to mention about the Professor Zbigniew Rediga. In my lecture, I would like to focus on the materials dedicated for the heart assist system, which were developed based on several projects. The most important project which has started our activity in the biomaterials, there's a project of Polish artificial heart, which was led and which was coordinated by the Foundation of Cardiac Surgery Development. We were responsible for the new modern materials and to implement our solution to medicine. Just as a short introduction, how we can divide the failure. We can divide in the acute failure, long-term failure, and patient with cardiomyopathy. These three different cases are qualified for the heart assist system. We can also divide for short-term and permanent support. And based on these statistics, we can choose whether we would like to, whether the surgeons would like to introduce the long-term system or short-term system. But coming back to the Polish Artificial Heart project, it was an extremely big activity. More than 40 teams took participation, and over 35 scientific research institutions. It was a part of 5 projects, 17 research tasks, and over 200 stages. We have, based on this project, we have gained 3 main working goals, strategic goals associated with the new technology implementation to the medicine. I would like to focus on what was on material science. The first task in our case was to analyze the quality of the materials which were deplanted. So, in the cooperation with the Foundation of Cardiac Surgery Development with the Department of Artificial Heart, we have received several chambers which were deplanted, and our task just at the beginning was to analyze and to answer why the complication occurred, what happened on the surface, and whether it was the danger of the bacterial biofilm formation from the bloodstream on the surface. For this reason, we have developed quite interesting and quite relatively sophisticated technique developed on the fluorescence and fluorescent hybridization. It was called FISH technique, fluorescent in situ hybridization. The method is quite simple. I would only take some laser point. We are preparing some pieces of the. We have prepared some pieces of the heart assist system for the analysis. It was introduced into the contact with some probes, with some molecular probes, and based on hybridization, the probes were associated with the nucleic acid of the specific organisms. And there are some results of based on a FISH method of the patients. In most cases, that complications occurred not because of the design of the heart assist system. It was caused because of the complications coming from this specific case. Our initial task associated with material science in the project of artificial heart was to design and introduce, was to modify the blood contacting surfaces of the heart assist system based on thin coating technology. Our main assumptions was to produce thin coatings with a good adhesion, with a high biocompatibility, and lack of substrate degradation. For this reason, in the cooperation with the Austrian Institute based on laser techniques, we have developed ceramic-based coatings with the elastic behavior. It was possible because of the special layer deposition and special technique of the thin coating growth, and it was even possible to implement such a thin coatings in the final task of our activity in the Polish Artificial Heart project to the specific parts of the pneumatic chamber, in the blood contacting chamber, in the prototype of the valve and the membrane, without any cracks and degradation. Of course, there's next. There's the design of Department of Artificial Heart Department, Foundation of Cardiac Surgery Development, and in this area, still in the frame of another project which were submitted and executed in the after Polish artificial heart, our activity was also found. But next project which came from the Polish artificial heart was based on basic research analysis associated with the niche leg structures. So the development of pneumatic chambers could based on our imagination and based on discussion with the colleagues from the Foundation of Cardiac Surgery Development of the base could be associated mostly on the sophisticated behavior of the surfaces which we are trying to develop. Based on the basic research project, we are trying to design, I would say, even intelligent coating which could absorb stem cells from the bloodstream and would influence on the cellular differentiation on the surface, and through the cellular differentiation, appropriate cellular differentiation, inhibit clot formation. Our idea was based on the idea of the three scientists who were awarded in 2007 by the Nobel Prize. It was called niche structures. In literature, we can find different design of the niche structures which could be introduced to the design of the surface appearance. In our case, we have chosen modular substrate stiffness. Based on thin coating technology, our idea was to introduce specific coatings with a specific technique in order to influence the surface to form kind of wrinkles. Because of the specific design of wrinkles, we wanted to influence on the behavior of the cells, especially stem cells, to differentiate into endothelium and via endothelium to inhibit clot formation. Of course, the special design and introduction of such complicated structures had to be analyzed and tested using even nanoscale, especially with the application of transmission electron microscope and other technique, which allowed us to have information how stable our coatings are and what is how the coatings could influence on the appropriate cellular differentiation. Application of the in our case, because of the style of basic research project, in our case we have purchased commercially available induced cells. There were cells which were redifferentiated from the human umbilical vein endothelium cells, and because only of the surface topography, because of the several different shapes of the topography, we wanted to influence of the cell differentiation. For this reason, we have applied platelet endothelium antibodies, also platelet leukocyte endothelium antibodies. We have also analyzed the cell junction and also amount of cells using DAPI markers, which allowed us to stain nucleus of the cells. Of course, the first two antigens which were conjugated with the fluorophores allowed us to see whether our surfaces has a strong or weak influence of the appropriate cellular differentiation. The more active, the better, of course. the more color we have, we can see, the better. And after several different analyses, several different optimization steps, we're able finally to conclude that the coatings, amorphous halogenated amorphous carbon doped with nitrogen with a specific thickness allowed to have appropriate wrinkles formed by itself only by via the appropriate technology, and could have an appropriate influence of the cell differentiation effect. So here's the final results of our analysis. Another possibility which allowed us to have an influence on the cell differentiation effect was associated with the specific strain of the substrate, elastic substrate, which was in this case was clinically used polyurethane, and the technology which was applied based on laser techniques. Here we have influenced and introduced the strain, and you could see again the similar analysis based on confocal microscopy technique. Without the strain, we have seen a weak differentiation into the towards the endothelium. When we increase the strain, we can see the increase of the probability of the differentiation into the endothelium. Then increasement of the strain allowed us to have a really strong influence of the appropriate differentiation effect into the endothelium. And the final results. Now I would like to change my topic a bit, much more changing from the applied basic research science into the applied research science. Here I would like to mention and present the most crucial, the most important results from the project, which was also executed in the international cooperation in between the Poland and Austria. And in Poland, we were cooperating with the Foundation of Cardiac Surgery Development. The main idea was to introduce and to design a new silent valve dedicated especially for the pneumatic heart assist system. Professor Bochenek has mentioned about the several different design of the artificial valves. Our idea was to design a new valve, a new artificial valve, which would be as safe as normally as the valves which are already introduced into the market. But our idea was to also eliminate the annoying sound. The first task was associated with the optimization of the mechanical properties and the determination of the fluids of dynamics. Here's the task was especially executed by the colleagues from the Foundation of Cardiac Surgery Development. For this reason, for the pneumatic chamber, we have designed two different valves, one different valves for inflow conduit, and B-leaflet valve for the outflow valve for the outflow. It was associated with the appropriate blood flow through the pneumatic chamber and the stability of the bloodstream which was flowing through the heart assist system. Because we were working, our idea was to design the valve which was based on clinically used polyurethanes. We wanted, our idea was to also introduce the scaffold which would allow us to reinforce the full structure of the valve. Here's another drawings of the outflow valve for the cone and the leaflets, and based on such drawings and such analysis, Also, the chamber had to be also redesigned. All this task, it was the activity of the colleagues of the Foundation of Cardiac Surgery Development. Our task as a material scientists was to prepare materials, hemocompatible materials, which could be applied by our colleagues from Zabrze. As mentioned before, we were working on the clinically used polyurethane purchased from DSM company Bio-80, and based on calorimetric analysis, we have found that polyurethane was stable in the simulated body fluids and also normal water medium. And what was observed, the problem occurred is mostly associated with the temperature. Because of the temperature increase, we've got different states coming from glass state to the viscoelastic state, and when we are looking on the loss module in the function of temperature, we can also see some glass transition states, which is also a really serious problems in the stability of the polyurethane, especially in the clinically use. But the further analysis has also shown that clinically used polyurethane has a problem with stability, which was especially associated with the cripping effect. Also shown here based on the stress strain analysis. What was our idea? Our idea was to reinforce of the valve through the metal scaffold. Simply said, we wanted to introduce the scaffold into the polyurethane structure of the valve. The main problem which occurred was to precise cut of the appropriate holes in the scaffold. In this case, we have applied a laser technique, which is quite precise, but not. But it was not free from some defects. With some defects which are shown here on the slide, we had to fight. Finally, we were able to design and elaborate. Or there's another problem which had to be eliminated, especially connected with the re-sputtering effect, especially on the border of the cut. Finally, after several trials, after several different optimization methods, we're able to prepare foil of the metallic scaffold based on stainless steel and titanium, modified with hemocompatible coatings. During my presentation, especially at the beginning of the description of this project, I have mentioned that the scaffold, based on our idea, had to be hidden inside the polyurethane. So why it was so important to modify the surface with the hemocompatible coatings? Our idea was to have highly hemocompatible materials on all steps of the valve design. Here's the design of the and elaborated cones of the inflow valve and cone of the outflow valve. Another picture. And finally, we were able to elaborate appropriate leaflets of the valves, which here you could see the metallic scaffold hidden inside the polyurethane cover. So it was completely covered by the high pressure pressing with the cooperation with the University of in Szczecin. Here's the design of the inflow valve, and here's the design of the B-leaflet valve. And another picture. After cutting, you could see how it was prepared. It was important that to not to have any holes inside in between the polyurethane and the scaffold. For this reason, we have applied scanning acoustic microscopy to check whether our product has a good quality. For the cones, we have applied different techniques. We have applied injection molding because of the different design and different appearance of the valve of this part of the valve. And here is the real prototype of the cones. In this case, it was not so important to cover the whole metallic scaffold by the polyurethane. It was the most important was to have a polyurethane inside, because after gluing everything together, we do not have the material exchange from the different phases. We've got only one phase, so changing the different parts of the chamber. We've got only the changes from the polyurethane to polyurethane. Here, titanium or the stainless steel is only visible from outside. The design of the valve was also designed taking under the consideration the need of cardiac surgeons. Of course, pneumatic chambers is normally located outside the human body. So in this case, it was also important to have to design appropriate windows for the surgeons to observe whether the bloodstream has an appropriate flow. Of course, as mentioned before, our design and all parts of the valve was prepared with taking under the consideration that the material had to be optimized into the hemocompatibility. So the surface optimization that the coatings which were applied on the metallic parts were modified with several coatings based on magneton spattering effect. Here, in this case, we have applied industrially applied magneton spattering, the different hybrid methods associated with a different even laser technology, which enabled us to elaborate highly sophisticated and high quality coatings which were prepared on the metallic part. Hemocompatibility was analyzed using dynamic instruments based on ISO 10993 rules. But the most important rule in this case was to analyze hemocompatibility, that our materials must not adversely interact with any blood component. In this case, we have applied clinically used instrument to analyze the quality of the blood, which is called impact R test. The test is based on Conan plate design. It is possible to introduce high shear stress because of the high RPMs, high rotation speed. In this case, we are testing the activation and aggregation blood. The tester is composed on two basic parts. So here's the well. On the bottom of the well, the sample is introduced. Then on the surface of the bottom, whole human blood is introduced. Then the cone is introduced, which is rotating with a speed of approximately 870 RPMs. In such conditions, of course, another testers, self-elaborated tester, also allowed us to confirm the results which were obtained by commercially available techniques. Based on a dynamic technique, dynamic blood-material interaction, we were able to analyze the blood-material interaction based on two specific receptors, especially P-selectin and integrin beta-3 2B3A. After the test, blood was taken from the surface of the sample and analyzed using flow cytometry technique, and also the blood which occurred on the surface was analyzed using confocal microscopy technique. In this case, as a positive control, we have also prepared adenosine diphosphate activated blood, which is the strong activator of the blood, and as a negative control, we have prepared citric blood. Our materials were analyzed and compared to clinically used polyurethane. Here, based on activation results, it was possible to qualify materials for promising, here marked with green color, materials which had to be eliminated, marked with red color, and the materials which had, I would say, neutral influence on the bloodstream were marked with a yellow color. For the further analysis, of course, we have chosen materials which were found on the green zone. Here you could see activation based on another receptor to be 3A, and also the similar qualification. Activation leads to aggregation. In our case, we have analyzed materials and qualified materials based on platelet aggregation. In our case, we have analyzed materials based on the probability and danger of the small platelet aggregate formation. Small platelet aggregate formation, there are two platelets found together, and big platelet aggregation, there are over two platelets found together. And also, based on this analysis, the materials were qualified for further analysis. Extremely important parameters which had to be also taken under the consideration were microparticles. Microparticles are formed where something unexpected and something wrong is happening in the direct contact with the cells. Here, in this case, we have taken under the consideration platelets. In the case of artificial materials, always some negative reaction occur inside the cell. In this case, there's an increasement of the calcium ions formation inside the cytosol site of the membrane. The reaction of the cell is to eliminate the products of the degradation of the cell via the forming kind of containers where product of degradation could be introduced and eliminated from the cell. They are so-called microparticles. Probability of the microparticles formation were analyzed in our cases, in our materials, in the comparison with the negative and positive control. And also based on this parameter, material were qualified and for further consideration. And final parameter which had to be also considered was monocyte platelet aggregate formation, and this kind of aggregate is formed via the P-selectin glycoprotein ligand 1 activation, and which enables to form the monocyte platelet formation. Of course, it's a negative reaction caused by the artificial materials introduction into the bloodstream, and the lower, of course, the better. The final task in the project was associated with simple in vivo tests on rabbits. Here in this case, we didn't introduce the valves. We have introduced the simple samples under the skin of the rabbits. We have taken 12 rabbits, 6 as a control and 6 as a rabbit, which allows us to analyze the quality of our materials. Here you could see the place of implementation of the samples. Of course, the task was executed in the cooperation with the animal surgeons. For the experiment lasts 1 month, and after 1 month, the samples were deplanted and analyzed histologically. What was important, we have analyzed the overall intradermal reactivity, and based on a presented table, we have found that our materials were not didn't endanger any negative reaction formation under the skin of the animal. After, as mentioned before, after the test, after 1 month, the samples from specific organs were taken and analyzed histologically, and based on histology analysis, we have found the appropriate images of all organs which were taken for analysis. Here we could see the final prototype of the valve, all composed valve glued together, the leaflet and the cone, and the chamber which was applied with inflow and outflow valve. Finally, the whole chamber was analyzed by our colleagues from Foundation of Cardiac Surgery Development using artificial heart model, and you could see the differences and some problems which occurred because of the high pressure, and differences in between the stainless steel and titanium. Such problems, of course, occurred, but we know how to improve it, and further activity associated with the further analysis, further work, allowed us to redesign the mesh of the scaffold to eliminate such complications which were presented before. A new project which has already started, next project which has already started, also in the cooperation with our awesome partners and the Foundation of Cardiac Surgery Development, is associated with a minimal and rotor pump, and the modification of the existing rotor pump. Maybe the first task are associated with the redesign and implementation of the new sophisticated material to the rotor pump. And here there's an introduction. Our idea was to redesign of the inflow conduit of the rotor pump in order to apply the specific porous rough structure to activate the surrounding cells to grow, but on the specific level. Here you could see the inflow conduit, which is introduced into the left chamber via the apex. Such roughness is so important to have a control on the control cell growth on the surface, but not to grow further and to close the inflow conduit. And you could see some complications which had to be eliminated. Our idea is to based on porous structure where selective laser sintering was applied to glue together titanium, I would say, spheres to form such surface. The second task is associated with new design of miniaturized pump, which could be introduced via the ascending aorta to the aortic valve, and to try to pump the blood from the left chamber to pure circular system. The material is based on Thiolben reactive monomers, and here there's a reaction of all materials which were designed and applied, implemented to the project, and the appearance of the materials which were prepared by our awesome colleagues. Such materials were sent to 3D printing to the company which is associated with the 3D printing, and such several different components, especially the rotor, will be printed based on these monomers to reduce the weight in the whole design. And again, our task was to analyze materials based on dynamic testers. Here we have prepared, together with our clinical colleagues, we have applied the appropriate protocol to analyze materials and to judge the blood-matter interaction and activity, because in the direct contact with our artificial materials. Based on several different dynamic tests and previously mentioned impact R test, our idea was to judge materials based on blood activation, especially based on P-selectin receptor and 2B3A, and analysis of the probability of the platelet aggregate formation. The surface is analyzed, and after such tester, the surface is analyzed using antibodies, fluorophore-labeled antibodies, which are specific for the specific receptor, which are visible on the cellular membrane. For this analysis, two basic instruments are normally used. First, flow cytometry technique, and second, confocal microscopy. In the case of confocal microscopy, the surface could, after direct contact with blood, could be visible like this. So not so interesting and complicated image, but application of the function which enables us to see how many pixels of the green channel we have and the red channel we have. We can see based on green channel, we can see how strong our materials could influence on the activity, and based on the red channel, we can see how strong our materials activate white blood cells, as it means the immunoresponse. And based on such analysis, we can qualify material. Of course, the lower the better. In this case, we found that all our materials were on the level of the negative control. So simply said, extremely positive. Here there's a results of the confocal microscopy when we have analyzed the activation of the platelets and immunoresponse, and based on such analysis, especially materials which expressed the highest values were eliminated. And also previously mentioned microparticles analyzed using IX 5, and based on microparticles, the most promising materials were finally chosen for next analysis.
Professor Meyer, I apologize. Can you hear us? Due to the serious time constrictions, we would like you to close the session as after a few slides, if possible, because we have. I apologize and thank you.
Maybe I would shortly conclude. So just shortly said, based on basic research, without basic research analysis, without basic research projects, applied research projects would not be possible. And our also idea, the most important aims and the targets associated with the materials dedicated for bloodstream are coming with a extremely close cooperation with other institutions, especially institutions which are able to apply our solution into the clinics, into the real world. So without such aims, our work would not be so interesting and would not be so we would not be so enthusiastic in our activities. Thank you very much.
Thank you very much, Professor Mayer. That was excellent presentation. We have no time to even summarize the session. So thank you to everybody. And now the time for Professor Gzik to introduce the next session.
Thanks to audience, thanks to the professor, our keynote lecture, for your interesting presentation. Thank you for discussion. Thank you to my co-chairman for the support me. And now I would like ask Dean of Faculty of Biomedical Engineering, Professor Paszenda, to continuing the conference. Thank you.
Szanowni Państwo, bardzo serdecznie witam Państwa na sesji specjalnej, sesji poświęconej jubileuszowi 10-lecia Wydziału Inżynierii Biomedycznej. Witam wszystkich Państwa, którzy do tej pory uczestniczyliście Państwo w konferencji, w sesji plenarnej. Również witam te osoby, które dołączyły do oglądania, dołączenia się z nami poprzez transmisję internetową w dzisiejszej uroczystości. Szanowni Państwo, pozwólcie, że w sposób szczególny przywitam naszego honorowego gościa, panią prezydent miasta Zabrze, Małgorzatę Mańkę-Szulik. Witam również pierwszego dziekana Wydziału Inżynierii Biomedycznej, panią profesor Ewę Piętkę, jak również pana Artura Polaka, prezesa APA Group. Proszę Państwa, planując uroczystości jubileuszowe, pierwszy taki okrągły jubileusz dla naszego wydziału, zastanawialiśmy, w jaki sposób zorganizować ten jubileusz. Postanowiliśmy, że nie będzie to jedno wydarzenie, że będzie to kilka wydarzeń, które będą uświetniały ten nasz jubileusz. Niestety sytuacja pandemiczna zmusiła nas do znacznego ograniczenia świętowania tego jubileuszu w trakcie całego roku. Powiem tylko, że udało nam się w trybie zdalnym zrealizować konferencję Information Technologies in Biomedicine. Tutaj duże słowa podziękowania dla pani profesor Piętki za organizację tej konferencji, jak również w trybie hybrydowym uroczystość symbolicznego wmurowania aktu erekcyjnego pod budowę Centrum Inżynierskiego Wspomagania Medycyny i Sportu, który jest projekt ten realizowany jest we współpracy z firmą Philips, z naszym strategicznym partnerem. Proszę Państwa, jubileusz 10-lecia można powiedzieć, że dla jednostki organizacyjnej, jakim jest wydział, to nie jest zbyt odległy jakiś czas. Natomiast dla pracowników, dla osób, które pracują na tym wydziale, to znaczna część, jeśli chodzi o aktywność zawodową. Proszę Państwa, 10 lat temu wielu z nas musiało podjąć ważną decyzję. Został powołany nowy wydział i wiele osób zastanawiało się, czy podjąć to wyzwanie, przejść na ten wydział nowy z swojego dotychczasowego macierzystego, czy jednak tej decyzji nie podjąć. Wiele osób zdecydowało się i dzisiaj wiem, że są bardzo z tego zadowolone, gdzie pracują, na jakim wydziale pracują. Proszę Państwa, tworzenie wydziału jako jednostki organizacyjnej to jest oczywiście proces ciągły. Ja nie będę tutaj w szczegółach omawiał wszystkich wydarzeń związanych z tworzeniem naszego wydziału, z jego historią. Chciałem tylko przypomnieć, że w 2006 roku kierunek Inżynieria Biomedyczna został uruchomiony przez Ministerstwo Nauki i Szkolnictwa Wyższego, a już w 2007 roku na Wydziale Automatyki, Elektroniki i Informatyki Politechniki Śląskiej dzięki inicjatywie pani profesor Piętki został uruchomiony kierunek kształcenia Inżynieria Biomedyczna. Kolejny rok, 2008, to decyzja rektora, pana profesora Andrzeja Karbownika, którego bardzo serdecznie pozdrawiam. To decyzja, propozycja o powołaniu nowego w uczelni naszej Wydziału Inżynierii Biomedycznej. Pan rektor powołał stosowny zespół, który miał wszystkie sprawy organizacyjne z planami studiów, strukturą organizacyjną przygotować. Na czele tego zespołu stanął pan profesor Jan Marciniak, wieloletni dyrektor Centrum Inżynierii Biomedycznej. I tutaj bardzo intensywnie współpracował również z panem profesorem Eugeniuszem Świtońskim. I tak przyszedł rok 2010, kiedy na wniosek rektora profesora Andrzeja Karbownika Senat Politechniki Śląskiej podjął decyzję o powołaniu nowego, jedynego w kraju Wydziału Inżynierii Biomedycznej. Stało się, proszę Państwa, od tego momentu zaczęliśmy tworzyć historię naszego wydziału. Proszę Państwa, nie będę teraz opowiadał w szczegółach, jakie działania podejmowaliśmy. Natomiast chciałbym Państwa zaprosić w taką krótką podróż. Podróż poprzez 10 lat historii naszego wydziału. Na tą okoliczność przygotowaliśmy specjalny film, który przygotowywaliśmy właściwie do ostatniego momentu, dlatego, żeby pewne fragmenty tego filmu odzwierciedlały aktualną rzeczywistość. Szanowni Państwo, zapraszam do oglądnięcia filmu przygotowanego specjalnie na dzisiejszą uroczystość. Można powiedzieć, że uczestniczymy w premierze tego filmu. Proszę bardzo o zaprezentowanie filmu. Szanowni Państwo, mieliście okazję zobaczyć krótki film dotyczący naszej dotychczasowej 10-letniej historii. Oczywiście to, co zostało zaprezentowane w tym filmie, to zaledwie jakaś cząstka tych wszystkich zdarzeń, które miały miejsce w ciągu tych 10 lat. Naszych sukcesów, czasami i może porażek, ale myśmy się nie poddawali. Proszę Państwa, jeśli mogę, chciałbym przytoczyć teraz słowa australijskiej pisarki Rhondy Byrne, która powiedziała: sam piszesz historię, pióro tkwi w Twoim ręku, a wynik zależy od tego, co wybierzesz. Proszę Państwa, od pierwszego dnia wzięliśmy pióro do swojej ręki i postanowiliśmy pisać naszą historię. Pisać, abyśmy byli dumni z naszego wydziału. Myślę, że wszyscy pracownicy, a na pewno ja jako dziekan Wydziału Inżynierii Biomedycznej jestem bardzo dumny z tych wszystkich osiągnięć. I tutaj chylę głowę przed moimi poprzednikami. Ja zaledwie dziekanem jestem od miesiąca, natomiast to przede wszystkim duże zaangażowanie wszystkich pracowników na Wydziale Inżynierii Biomedycznej pod kierunkiem dotychczasowych dziekanów, pani profesor Ewy Piętki i pana profesora Marka Gzika. Proszę Państwa, mamy oczywiście w sobie również dużo pokory. Powiemy, że te wszystkie sukcesy, które osiągnęliśmy, to nie tylko efekt naszej ciężkiej pracy, ale to wszystko również efekt pomocy określonych ludzi czy instytucji. Proszę Państwa, już w 2012 roku z inicjatywy ówczesnego dziekana wydziału, pana profesora Marka Gzika, postanowiliśmy honorować osoby, instytucje zasłużone dla naszego Wydziału Inżynierii Biomedycznej. Zaprojektowaliśmy stosowną statuetkę oraz wyróżnionym wręczamy zawsze stosowne listy gratulacyjne. Proszę Państwa, już w 2012 roku kapituła w myśl opracowanego regulaminu przyznała pierwsze 4 statuetki zasłużone dla Wydziału Inżynierii Biomedycznej. Te pierwsze statuetki trafiły do rąk pani prezydent miasta Zabrze Małgorzaty Mańki-Szulik. Pani prezydent, przy tej okazji nie mogę pozwolić sobie jeszcze na kilka słów. Bardzo dziękujemy za wszystko to, co pani prezydent, władze samorządowe na czele z panią prezydent robią dla naszego wydziału. I tu chcę powiedzieć, proszę Państwa, że nie tylko dla naszego wydziału, ale my to czujemy. My czujemy to w tym mieście, w Zabrzu, że tutaj wiele się dzieje. Miasto dynamicznie się rozwija. Są stwarzane warunki bardzo dogodne dla rozwoju nauki, turystyki poprzemysłowej, ale i innych branż. Także pani prezydent, jeszcze raz moje najserdeczniejsze podziękowania, bo proszę Państwa, ta współpraca nie zakończyła się, ta współpraca trwa, jest dalej wiele pomysłów, które byśmy chcieli wspólnie realizować i mamy tutaj bardzo duże wsparcie władz samorządowych. Statuetkę również przekazaliśmy rektorowi Politechniki Śląskiej w kadencji 2008-2016 panu profesorowi Andrzejowi Karbownikowi. Z tego miejsca również panu profesorowi bardzo dziękujemy za tą propozycję, za tą inicjatywę, że dzisiaj możemy szczycić się, a mam nadzieję, że i cała uczelnia może szczycić się, że w swojej strukturze ma jedyny wydział w Polsce, Wydział Inżynierii Biomedycznej. Kolejne 2 statuetki przyznaliśmy panu profesorowi Eugeniuszowi Świtońskiemu oraz panu profesorowi Marciniakowi. To były 2 osoby, które włożyły ogromny wkład na etapie organizowania wszystkiego i później, kiedy wydział już funkcjonował, dalej bardzo mocno wspierały nas w naszych wszystkich działaniach, żeby wydział się rozwijał. Proszę Państwa, uroczystość jubileuszowa to również okazja, żebyśmy podziękowali kolejnym osobom czy instytucjom. I tutaj chciałem powiedzieć, że jeszcze w poprzedniej kadencji pan profesor Marek Gzik jako dziekan i przewodniczący kapituły podjął taką inicjatywę, żebyśmy wyróżnili kolejne osoby, które przyczyniły się do rozwoju Wydziału Inżynierii Biomedycznej. Tymi osobami, pozwolę sobie najpierw wymienić te osoby, tymi osobami są Jego Magnificencja Rektor Politechniki Śląskiej, Przewodniczący Konferencji Rektorów Akademickich Szkół Akademickich, pan profesor Arkadiusz Mężyk. Pani profesor Ewa Piętka, pierwszy dziekan Wydziału Inżynierii Biomedycznej, pan Artur Polak, prezes APA Group, pan profesor Andrzej Hajdasiński, pan profesor pracuje na Nairobi Business University, natomiast również od kilku lat pewnego czasu pracuje na naszym wydziale. I również chcieliśmy uhonorować firmę Royal Philips, firmę, która jest strategicznym partnerem w realizowanym projekcie Assist Med Sport Silesia. Szanowni Państwo, chciałbym teraz rozpocząć tę część naszej sesji, która będzie dotyczyła wręczenia stosownych statuetek. Szanowni Państwo, tak jak już wspomniałem, statuetkę Zasłużony dla Wydziału Inżynierii Biomedycznej chcielibyśmy wręczyć Jego Magnificencji Rektorowi Politechniki Śląskiej, panu profesorowi Arkadiuszowi Mężykowi w podziękowaniu za wsparcie finansowe i organizacyjne dla rozwoju Wydziału Inżynierii Biomedycznej oraz osobiste zaangażowanie w budowę Centrum Inżynierskiego Wspomagania Medycyny i Sportu. Niestety Jego Magnificencja nie może bezpośrednio uczestniczyć w dzisiejszej uroczystości. Łączył się z nami za pomocą internetu już w trakcie konferencji, natomiast pan rektor uczestniczy również w spotkaniu organizowanym, w telespotkaniu organizowanym przez ministerstwo. Jeśli będzie taka okazja jeszcze w trakcie dzisiejszej uroczystości, to panu rektorowi przekażemy statuetkę, natomiast jeśli takiej możliwości nie będzie, to w najbliższym możliwym czasie poproszę pana profesora Marka Gzika również o wspólne takie wręczenie Jego Magnificencji tej statuetki. Proszę Państwa, kolejna statuetka to statuetka Zasłużony dla Wydziału Inżynierii Biomedycznej i statuetka przyznana pani profesor Ewie Piętce. Pani profesor Ewie Piętce, czyli pierwszemu dziekanowi Wydziału Inżynierii Biomedycznej w podziękowaniu za uruchomienie kierunku Inżynieria Biomedyczna w Politechnice Śląskiej, za wkład w rozwój organizacyjny, naukowy i dydaktyczny oraz budowę pozycji naukowej Wydziału na arenie krajowej i międzynarodowej. Pani profesor jest obecna, jest razem z nami. Zapraszam panią profesor tutaj na środek. A pana profesora Marka Gzika poproszę o pomoc przy wręczaniu statuetki. Pomysłodawcy przekazuje.
Profesor, cieszę się, że mogę pani profesor, wręczając tą statuetkę, wyrazić naszą głęboką wdzięczność za to, co pani profesor uczyniła dla naszego wydziału, dla naszej społeczności akademickiej i życzyłbym sobie, żeby ta współpraca, która ja oceniam ją bardzo dobrze, żeby jeszcze trwała przez wiele lat. A pani profesor życzę zdrowia i wszelkiej pomyślności.
Dziękuję bardzo.
Najlepszego, profesor.
Pani profesor, ja również składam serdeczne gratulacje i życzę dużo zdrowia i wielu dalszych sukcesów i stosownych. Dziękuję bardzo. Może pani profesor może sobie na chwileczkę odłożyć, a poproszę panią profesor o zabranie głosu.
Panie dziekanie, pani prezydent, szanowni państwo również zebrani przed komputerami. Przyjmując tą statuetkę, mam na myśli od razu cały zespół osób, które pracowały, abyśmy dzisiaj mogli mówić o sukcesach, abyśmy dzisiaj mogli mówić o zasłużonych dla wydziału. Mam tutaj na myśli całe kolegium dziekańskie poprzednich 2 kadencji z panem dziekanem Markiem Gzikiem, całe kolegium dziekańskie, w którym również uczestniczył pan profesor Zbigniew Paszenda. Ale proszę mi również pozwolić na pewne takie moje osobiste uwagi i spotkaliśmy się z grupą bardzo zaangażowanych osób wiele lat temu, to jeszcze było na Wydziale Automatyki, grupą doktorantów i z nimi razem podjęliśmy właśnie ten trud przygotowania nowego kierunku studiów. Ich zaangażowanie w opracowanie programów, opracowanie nowych przedmiotów, laboratoriów, wykładów, również prace związane z promocją tego kierunku nie przeszkodziły w rozwoju ich pracy naukowej. To skutkowało tym, że kiedy tworzyliśmy nowy zespół, kiedy tworzyliśmy nowy wydział, nasz zespół, łącznie z zespołem pana profesora Mitasa, liczył już 13 nauczycieli akademickich. Ten zespół do dnia dzisiejszego podwoił się. Podwoił się dzięki projektom, które pozyskujemy i projektom, które realizujemy. Mamy w tej chwili 6 profesorów, 10 adiunktów i grono wspaniałych doktorantów. Mówię o tym dlatego, że skoro przez te wszystkie lata dzieliliśmy trudy, również ryzyko tej pracy, to chciałabym również dzisiaj z nimi podzielić się tą radością otrzymania tej statuetki. Myślę, że jest to statuetka dla całej naszej Katedry Inżynierii Informatyki i Aparatury Medycznej i chcę powiedzieć, że jestem dumna ze wszystkich pracowników tej katedry, którzy u nas byli i są w tej chwili. Dziękuję bardzo.
Dziękujemy bardzo pani profesor za słowa tutaj skierowane do wszystkich uczestniczących w dzisiejszej naszej uroczystości. I proszę państwa, chciałbym przystąpić do wręczenia kolejnej statuetki dla pana Artura Polaka, prezesa APA Group, w podziękowaniu za wsparcie finansowe i organizacyjne dla rozwoju Wydziału Inżynierii Biomedycznej, w szczególności za utworzenie laboratorium Leonardo Lab oraz udział w projektach badawczych budujących markę naszego wydziału. Panie prezesie, bardzo serdecznie zapraszam tutaj do nas na środek. Panie profesorze, proszę o przekazanie.
Panie prezesie, drogi Arturze, my jesteśmy przyjaciółmi, tak oceniam nasze relacje, ale jest mi niezwykle przyjemnie i miło, że mogę wręczyć tę statuetkę, dziękując Tobie za Twoje osobiste zaangażowanie, za wsparcie firmy APA dla rozwoju Wydziału Inżynierii Biomedycznej i liczymy na dalszą dobrą współpracę. Także serdecznie dzięki za wszystko, co dla nas robicie. Proszę, przyjmij to jako wyraz naszej głębokiej wdzięczności. Dziękuję.
Ja również dołączam się do tych wszystkich słów. Panie prezesie, bardzo dziękujemy za wszystko to, co udało się zrealizować na naszym wydziale. Wydział dzięki współpracy z panem, z firmą dalej się, że tak powiem, dynamicznie rozwija. Także bardzo serdecznie dziękujemy. Proszę przyjąć ten stosowny list gratulacyjny. Dziękuję. Dziękujemy. Panie prezesie, prosilibyśmy o zabranie głosu i kilka słów.
Szanowni Państwo, Pani Prezydent, Panie Dziekanie, Panie Profesorze, być w takim zaszczytnym gronie to naprawdę jest niesamowita sprawa. To pokazuje, że w życiu warto się starać. Ja jestem absolwentem Politechniki Śląskiej, w związku z tym moje działania są troszkę nakierowane na połączenie tak zwanego biznesu z nauką. To jest coś, czego mi osobiście bardzo brakowało i wszystko zaczyna się od spotkań takich międzyludzkich. To, co udało się Państwu stworzyć w takim ekosystemie, wydaje mi się, że jest absolutnie wyjątkowe. Pani profesor mówiła przed chwilą o zbudowaniu takiej grupy ludzi pozytywnie nastawionych. W czasie naszych spotkań, w czasie prowadzenia projektów, rzeczywiście to emanuje. Wszystkie osoby są bardzo zaangażowane, są bardzo ciekawe świata. Państwo zmieniacie świat na lepsze. W związku z tym to jest też taka wizja i misja tego, co my robimy jako firma i ja bardzo doceniam każdą osobę, która chce coś zrobić, co robi od siebie, z takiego własnego zaangażowania, z własnej motywacji, a nie tylko z motywacji zewnętrznej. W związku z tym wierzę, że nasza współpraca została zapoczątkowana. Ona, mam nadzieję, że będzie kontynuowana. My ze swojej strony będziemy wkładać w tą współpracę dużo serca i zaangażowania. Mam nadzieję, że takie obopólne połączenie takiej funkcji gospodarczej i właśnie naukowej pozwoli, że nasz region bardzo na tym zyska i obserwując w ogóle Politechnikę jako uczelnię badawczą, ona wykonała kosmiczny skok i tutaj myślę właśnie, że ten wyjątkowy wydział, który jest ulokowany w Zabrzu, on świetnie zmienia region i powoduje to, że możemy być naprawdę dumni, że nie pracujemy siłą mięśni, a siłą intelektu i tutaj wierzę, że to rzeczywiście zmieni pozycję nas jako osoby, które funkcjonują w regionie, w Polsce, że możemy być dumni właśnie z tego wszystkiego, co Państwo tworzycie i co możemy obserwować w ostatnich latach. Także bardzo doceniam i bardzo dziękuję i pozostaję do dyspozycji. Dziękuję bardzo.
Dziękuję bardzo, panie prezesie.
Możemy zrobili zdjęcie takie jedno.
Szanowni Państwo, proponuję, aby teraz aby prasa ma swoje prawa. Chcieliśmy zrobić takie pamiątkowe zdjęcie. Jeśli moglibyśmy zaprosić panią wyróżnione osoby, może tutaj. Z przodu. Wiesz, może panią prezydent gdzieś. Pamiątkowe zdjęcie. Dziękujemy bardzo. Jeszcze raz gratuluję wyróżnionym. I proszę Państwa, kolejna statuetka. Statuetka dla pana profesora Andrzeja Hajdasińskiego. Dla pana profesora w podziękowaniu za zbudowanie partnerskich i strategicznych dla rozwoju Wydziału relacji z firmą Philips oraz za osobiste zaangażowanie w realizację projektu Śląskie Centrum Inżynierskiego Wspomagania Medycyny i Sportu. Szanowni Państwo, pana profesora nie ma dziś z nami, przebywa w Holandii, natomiast jestem przekonany, że łączy się tutaj z nami, ogląda transmisję, także panie profesorze bardzo serdecznie pozdrawiamy, bardzo serdecznie gratulujemy statuetki i przy najbliższej możliwej okazji statuetka panu profesorowi zostanie wręczona. I proszę Państwa, kolejna, piąta statuetka to statuetka już dla firmy Royal Philips, dla strategicznego partnera w podziękowaniu za wsparcie finansowe, przekazane technologie informatyczne oraz zaangażowanie w realizację projektu Centrum Inżynierskiego Wspomagania Medycyny i Sportu. Szanowni Państwo, z pewnych względów przedstawiciele władz firmy nie mogą uczestniczyć w dzisiejszych, to również ta sytuacja pandemiczna. Organizowanie tego wydarzenia zmusiło nas do ograniczania liczby osób bezpośrednio zaproszonych. Natomiast chciałem powiedzieć, że w najbliższym czasie, już może w przyszłym tygodniu, specjalna delegacja uda się do władz firmy na czele z jego magnificencją rektorem Politechniki Śląskiej i stosowną statuetkę przekaże firmie jako wyraz naszego podziękowania. Proszę Państwa, to tyle, jeśli chodzi o wręczenie statuetek. Natomiast, proszę Państwa, teraz jest czas na kolejny element dzisiejszego programu i poproszę pana profesora Marka Gzika o wyjście na środek.
To nie wiedziałem, że taki punkt programu jest jeszcze przewidziany.
Panie profesorze, to była jedna z najbardziej skrywanych tajemnic, jeśli chodzi o program dzisiejszej uroczystości, więc na pewno ten punkt nie znalazł się w oficjalnym programie. Panie profesorze, szanowni państwo, wydaje mi się, że jest to doskonała okazja do tego, aby w tym momencie podziękować panu profesorowi. Kadencyjność na uczelni jest rzeczą naturalną. Pan profesor był dziekanem 2 kadencje na naszym wydziale, w latach 2012-2016 i 2016-2020, a ja miałem tę przyjemność współpracować w Kolegium Dziekańskim z panem profesorem. Szanowni panie profesorze, w imieniu całej społeczności Wydziału Inżynierii Biomedycznej, w imieniu wszystkich pracowników, studentów, doktorantów składamy najserdeczniejsze podziękowania. Podziękowania za ten niestandardowy trud, zaangażowanie dla kreowania, budowania pozycji naszego wydziału. Panie profesorze, żadne słowa nie wypowiedzą tego, co odczuwam, co w imieniu wszystkich pracowników chciałbym teraz przekazać. Także mogę tylko powiedzieć, Marku, dziękujemy bardzo.
Serdecznie dziękuję.
Panie profesorze, proszę przyjąć
Super.
i stosowny list
Dziękuję bardzo.
gratulacyjny, umieścić go w stosownym miejscu, gdzieś w gabinecie.
Dziękuję bardzo.
Proszę Państwa, bycie dziekanem, ja dopiero się o tym przekonuję powoli, natomiast bycie dziekanem to bardzo duże wyzwanie. Ja sobie to tak porównuję, że to jest tak jak okręt płynie przez wzburzony ocean. Są fale, wieje wiatr z różnych stron, jest wiele przeciwności, ale za chwilę wychodzi słońce i statek bezpiecznie pływa. A to, czego najbardziej kapitanowi na statku potrzeba, to jest kompas. To jest kompas i w tym momencie chciałem panu profesorowi przekazać taki symboliczny kompas, żeby on wskazywał nie tylko kierunki geograficzne, ale pan profesor ma kolejne wyzwania. Od 1 września pan profesor jest przewodniczącym Rady Dyscypliny Inżynieria Biomedyczna Politechniki Śląskiej, więc chciałbym, żeby ten kompas, przynajmniej symbolicznie, wskazywał nowe kierunki, w którym ta dyscyplina naukowa, inżynieria biomedyczna ma podążać na naszej uczelni i żeby nasi pracownicy całej uczelni mogli się dynamicznie rozwijać w tym obszarze. Panie profesorze, niech ten kompas wskazuje właściwe kierunki do podejmowania odpowiednich decyzji. Marku, jeszcze raz gratuluję i dziękuję bardzo.
Dziękuję serdecznie. Dziękuję.
Czy mógłbym prosić właśnie teraz jeszcze o symboliczne zdjęcie. Dziękuję bardzo.
Dziękuję bardzo.
Dziękuję panie profesorze.
Serdecznie.
Jeśli pan profesor ma taką wolę, to proszę o zabranie głosu.
Panie prezydent, panie dziekanie, no, czuję się wzruszony, bo 8 lat, myślę, że dobrej współpracy i ja już wyraziłem to i mówiłem o tym kilkukrotnie, że tak naprawdę największy sukces tych 8 lat, kiedy miałem przyjemność zarządzać wspaniałym zespołem pracowników, zarówno naukowych, doktorantów, studentów, cała nasza administracja, to naprawdę szereg wspaniałych ludzi wspieranych przez miasto. Mój wielki ukłon w stronę pani prezydent i całego samorządu miasta Zabrze, w kierunku władz uczelni, w kierunku wielu przyjaciół, tak jak właśnie reprezentacja firmy Philips, firmy APA i wielu innych, musiałbym naprawdę bardzo długo wymieniać, ale to, co się udało zbudować na naszym wydziale, z czego ja mam największą satysfakcję, to kapitał ludzki. To jest to, szanowni państwo, że podczas chociażby mojej wizyty ostatnio w Eindhoven miałem okazję zorientować się, że naprawdę jesteśmy w wymiarze międzynarodowym postrzegalni bardzo pozytywnie i nasz potencjał wciąż jak gdyby rośnie i widzą w nas tak wielcy partnerzy jak firma Philips, kogoś, z kim można współpracować a mam nadzieję, że w przyszłości dzielić kolejne sukcesy. Także za te 8 lat, kiedy wielokrotnie to ja w roli dziekana, że tak powiem, cały ten splendor sukcesów gdzieś spływał na mnie, ale to były sukcesy, które wspólnie osiągaliśmy jako zespół całego naszego wydziału, wspierany, tak jak mówię, przez bardzo licznych naszych przyjaciół. Szanowni Państwo, serdecznie dziękuję za te 8 lat. Bardzo dziękuję za to dla mnie taki moment też wyjątkowy. Cieszę się, że mój następca, profesor Paszenda, z którym zbudowaliśmy, myślę, że bardzo wyjątkowe, przyjazne, ale takie relacje, które też budują pozycję naszego wydziału. Cieszę się, że Zbyszku doceniasz to, że 8 lat tej współpracy, bo wiesz blisko, będąc tu razem ze mną, ile to kosztowało nas też zaangażowania i czasu poświęconego, ale to, że jest kontynuacja tego, co dokonaliśmy przez 8 lat, to z tego mam dużą satysfakcję i cieszę się, że kolejne władze naszego wydziału raz, że będą podejmowały ambitne wyzwania, ale też doceniają to, co wspólnie dotychczas zrobiliśmy. Dziękuję wszystkim kierownikom katedr, dziękuję profesorom, dziękuję adiunktom, dziękuję studentom, dziękuję całej administracji naszego Wydziału i Politechniki Śląskiej. Także serdecznie dziękuję i tylko powiem, szanowni państwo, że nie kończę mojej misji po powrocie z Holandii. Jestem naładowany bardzo pozytywną energią i kolejne wyzwanie to właśnie takie, żebyśmy zbudowali bardzo silne centrum, już nie centrum śląskie inżynierskiego wspomagania, ale centrum, proszę państwa, centrum innowacji w medycynie i sporcie, które chcemy, żeby wkrótce stało się europejskim. Ja wierzę głęboko, że ta nasza dobra dotychczasowa współpraca i nasi partnerzy, to wszystko wspólnie razem pozwoli nam zbudować coś w tej części Europy, już nie boję się tak powiedzieć, coś absolutnie wyjątkowego. Bardzo serdecznie za wszystko jeszcze raz dziękuję.
Dziękujemy. Dziękujemy bardzo, panie profesorze, za te słowa skierowane również do całej społeczności naszego wydziału. Szanowni państwo, poproszę panią prezydent miasta Zabrze, Małgorzatę Mańkę-Szulik o zabranie głosu.
Panie dziekanie, szanowni państwo, drodzy studenci, nie mogło mnie tu dziś nie być, bo przecież towarzyszyłam tej idei od samego początku i myślę, że to, co dziś obserwujemy, w czym uczestniczymy, to taki najlepszy przykład złotego trójkąta współpracy nauki, biznesu, samorządu. Samorząd wspiera, samorząd wzmacnia państwa działanie, ale tak naprawdę to ten ogromny wkład w sukces, który mierzy się krótkim okresem czasu, 10 lat w historii 75-lecia Politechniki Śląskiej. To ogromne zaangażowanie wielu ludzi. Miałam to szczęście, że przeszliśmy przez okres budowania, szczególnie z panem profesorem Markiem Gzikiem i bardzo sobie cenię to działanie, które przynosi efekty nie regionalne, nie ogólnopolskie, ale europejskie. Jeździmy po świecie, jeździmy po Europie, obserwujemy ośrodki naukowo-badawcze i trzeba powiedzieć, że mamy takie ośrodki tu, na Śląsku, w Politechnice Śląskiej, w Zabrzu. Zabrze jest kojarzone z medycyną, tak więc inżynier i lekarz muszą iść pod ramię, bo dziś przecież coraz częściej bez pomocy inżynierów trudno wyobrazić sobie skuteczność medycyny. Dlatego za te 10 lat, wydawałoby się za ten krótki odcinek czasu, serdecznie dziękuję. Wybrzmiewały słowa zadowolenia, radości. Myślę, że wszystkich powinna rozpierać duma i oby z tą dumą podejść w następne 10 lat, w następne jubileusze. Panu dziekanowi gratuluję. Wierzę, że to będzie równie dobra współpraca jak z poprzednim dziekanem. Panu dziekanowi Gzikowi również dziękuję serdecznie. Życzę dalszych sukcesów w nowych wyzwaniach, a państwu życzę, byście byli znani w całym świecie, bo na to zasługujecie. Wszystkiego dobrego. Gratuluję serdecznie.
Dziękujemy bardzo.
Proszę bardzo.
Pani prezydent za wszystko.
Serdecznie. I tą symboliczną wiązankę dla wszystkich pracowników wydziału. Bardzo proszę.
Dziękuję bardzo pani prezydent.
Wszystkiego dobrego.
Dziękuję bardzo. Pozwolę sobie uważać.
Pani Prezydent, w imieniu całej społeczności Wydziału Inżynierii Biomedycznej bardzo dziękuję za przybycie na dzisiejszą uroczystość, mimo tej sytuacji epidemicznej, za słowa skierowane do nas. My bardzo, już wybrzmiewało to, jesteśmy dumni z tego raz, co osiągnęliśmy, ale jesteśmy pełni wdzięczności za okazaną pomoc tutaj, bo ta pomoc, proszę Państwa, jej nie da się w jakikolwiek sposób po prostu policzyć. To jest naprawdę bardzo duża życzliwość. Tutaj, tak mi się wydaje, bije serce inżynierii biomedycznej w Zabrzu. Tu są właśnie tworzone warunki do rozwoju jednostek opracowujących różnego rodzaju technologie mające służyć pacjentom dla ich poprawy zdrowia. Także Pani Prezydent, przepraszam, jeszcze raz bardzo serdecznie dziękuję za udział w dzisiejszej uroczystości, za te 10 lat. Ja mogę powiedzieć, że ja zbieram tą śmietankę, ja dopiero jestem miesiąc dziekanem, pan profesor Marek Zik napracował się, a ja zbieram gratulacje. No ale taka jest kolej rzeczy. Nie ja ustalałem lata, kiedy zmieniają się kadencje, natomiast ja myślę, że razem tutaj z panem profesorem Markiem Gzikiem odczuwamy tą radość i podziękowania tutaj dla całego miasta Zabrze, władz samorządowych i za to wszystko, co udaje się wspólnie realizować. Także mamy nadzieję, że również miasto będzie dumne z naszego wydziału, z osiągnięć i z tego, co będzie się działo, a będzie się działo dużo. Także już myślę, że jak będziemy obchodzić 15. rocznicę wydziału, to już ten filmik będzie zdecydowanie dłuższy i będzie więcej elementów pokazujących nasze osiągnięcia. Szanowni Państwo, bardzo wszystkim dziękuję za udział w tej sesji. Dziękuję Pani Prezydent, dziękuję Panu Profesorowi Markowi Gzikowi i dziękuję za przybycie wyróżnionym, Pani Profesor Piętce, Panu Prezesowi Polakowi. Dziękuję wszystkim Państwu, którzy połączyliście się i zechcieliście poświęcić ten czas, aby uczestniczyć w tej sesji jubileuszowej. Chcieliśmy Państwa wszystkich gościć bezpośrednio, w sposób tradycyjny. Natomiast sytuacja epidemiczna na to nie pozwoliła, ale i tak cieszymy się bardzo z dużego odzewu, jeśli chodzi o zaproszenia przesłane na dzisiejszą uroczystość. Także wszystkim Państwu bardzo serdecznie dziękuję. Dziękuję wszystkim, którzy przyczynili się do zorganizowania tej uroczystości w trybie takim hybrydowym, prawda? Dziękuję, że mogliśmy uroczystość transmitować z wykorzystaniem telewizji Politechniki Śląskiej, internetowej. Także wszystkim bardzo serdecznie dziękuję i szanowni Państwo, zapraszam do udziału w kolejnych wydarzeniach naszej konferencji. Dzisiaj jeszcze sesja posterowa, natomiast jutro serdecznie zapraszam o godzinie 9. Jest specjalna sesja pod patronatem American Heart of Poland, gdzie będą prezentowane bardzo ciekawe referaty, a o godzinie 11 sesja studencka, gdzie studenci będą prezentować swoje osiągnięcia naukowe, a również spotkanie dziekanów już w takim bardziej zamkniętym gronie wydziałów realizujących kształcenie na kierunku inżynieria biomedyczna, aby dyskutować właśnie nad rozwojem tego kierunku i żeby absolwenci mogli znaleźć zatrudnienie w jednostkach szpitalnych po to, żeby skuteczność i jakość leczenia w Polsce uległa zdecydowanej poprawie. Szanowni Państwo, bardzo serdecznie dziękuję za udział w dzisiejszej uroczystości.